Assalamu alaikum, everyone. I welcome you all in the Symposium for Pediatric Palliative Care. Let's talk about the format today. We'll have 3 guest speakers and we'll have 3 talks. Each talk will be of 30 minutes, followed by a case presentation. So moving on to our first talk. The first talk will be delivered by Dr. Shehzadi Resham. And let me introduce her. She did her graduation from St. Medical College. And after that, she joined Aga Khan University Hospital and pursued her training. She completed 3 years of fellowship program in pediatric. She did her pediatric residency and then fellowship in pediatric hematology oncology. Having recognized the huge vacuum in pediatric palliative care, she voluntarily stepped in and decided to establish pediatric palliative care services in Karachi and in the region as well. So she completed her global palliative care fellowship from St. Jude's Hospital, thus becoming the pioneer in pediatric palliative care in Pakistan. So I welcome you here, and it's always a treat to listen from her. Thank you, Rishan.
Assalamualaikum and a very good morning. Thank you so much for the generous introduction. So I think the topic of communication, I think it's very close to everyone's heart, and I think it's a part and parcel and very much important when we talk about caring for kids with cancers and chronic life-threatening and life-limiting illness. So I have nothing to disclose. So I'll be talking about what is effective communication and what is most important for families and patients in communication, and how can we enhance our communication skills, and how can we improve our patient interactions in pediatric oncology. Before we move forward, I think we are 11 or 10 people here. I think let's pair up for just 1 or 2 minutes and just come up with one of the moment that you remember while you had a conversation, any kind of conversation with the family and the patient. If you can just pair up with whoever is sitting next to you. It's just a 1 minute thing. And I'll just buzz you after a minute. Any moment or interaction after the conversation or during the conversation that you can remember and that had brought change in your practice or that you have find challenging. Pair up with your partner. आप अकेले नहीं सोचो। अच्छा, वो माइक में नहीं बोलूंगी तो फिर आवाज नहीं जाएगी ना? डॉक्टर शकीला को नहीं जाएगी? अस्सलाम वालेकुम डॉक्टर शकीला।
Alaikum salam. I can hear you very well.
So I think I think we are done with 2 minutes time. So anyone would like to volunteer? Or I should just pick and choose? अच्छा, हमारे पास माइक्रोफोन है। तो कोई conversation जो
तो बेसिकली ये कन्वर्सेशन में वो रिलेट कर नॉट जो मेरी पेशेंट्स की फैमिली से हुई, एक्चुअली इट इज़ माय ओन एक्सपीरियंस व्हेन आई गॉट द न्यूज़ ऑफ माय मदर ओवेरियन कैंसर, और जो डॉक्टर्स के साथ उस वक्त मेरी कन्वर्सेशन हुई और जो फीलिंग्स उस वक्त मेरी थी, तो मुझे लगता है उसके बाद मेरे अंदर बहुत ज़्यादा एम्पैथी आ गई और मुझे अंदाज़ा ज़्यादा हुआ कि किस पेशेंट्स और उनकी फैमिलीज को किस प्रोसेस से और किन
So-
चैलेंजेस से गुजरना पड़ता है
So did you
और उसमें डॉक्टर्स का अच्छा बोलना, अच्छी तरह कम्युनिकेट करना, इट मैटर्स अ
so
लॉट.
anything particular in that communication that you feel that you felt that was missing or that could have done in a better way? Anything that any one word that
एक्चुअली उनको पता था कि मैं ऑन्कोलॉजिस्ट हूँ तो
so they were trying to-
कन्वर्सेशन उतनी डिटेल में नहीं हुई जितनी एक्चुअली फैमिलीज के
Okay.
साथ होती हैं. दे वर कीपिंग इन माइंड कि मुझे आई नो मोस्ट ऑफ द थिंग्स.
Right. Okay.
So, yeah.
Thank you for sharing. Okay. Dr. Adil.
So when I remember when my mother was getting treated with terminal cancer, and she said to me one thing. She said, "Doctor Adil, मैनू कोई सड़ियल डॉक्टर को ना लेके जाइए. बाकी ठीक होना या नहीं ठीक होना वो अलग बात है, मगर मुझे सड़ियल डॉक्टर के पास ना लेके जाना."
तो उन्होंने सड़ियल की डेफिनेशन आपको समझ में आई वो क्या थी?
वो जो जरा सख्त बात करना नहीं
लज्जा।
चाहते, and ledger, and just straightforward, almost showing no emotion or no empathy. वो वाली बात है. So that's something which really stuck with me.
I know. Thank you for sharing. Anyone? Yeah, Dr. Harun.
So I'll share an interaction as a doctor with a patient. I had a patient which was a very tough one. She was a lady with a very tough family dynamics. Her husband was in jail, and she had 2 young children, and the children were very upset because they were living at the Nani's house, and they would come to me, to my office every day. And the boy obviously was a teenager, 13 years old, and his biggest thing that used to upset him was कि मामू का ड्राइवर है तो वो पहले मामू के बच्चों को छोड़ता है और मैं रोज लेट होता हूँ. You know, something as simple as that. Anyways, my habit is, because I still find after nearly 15 years of pediatric palliative care practice by default जो करनी पड़ती है मुझे, talking to children very challenging. So when I have to speak to any family or a child, I actually still rehearse in the office. I write down what questions I can expect and I rehearse, because sometimes I get very emotional. I'm very close to my children. So I get very upset, especially if the child is my child's age. So I was talking to this girl who's 15 and telling her about her mother's cancer, that, you know, she's dying and everything. But I was consoling her कि नहीं, जिंदगी में सब कुछ ठीक हो जाता है, ये हो जाता है, वो हो जाता है. And you anticipate questions, so you prepare them. And she asked me a question कि, you know, आपकी अम्मी तो नहीं मरी थी जब आप 15 साल के थे, तो how do you know what I'll go through? And there was about a 20-second gap because I had not prepared for this question, and no one had ever asked me this question. And that was one of the most challenging question ever somebody put me, was by a 15-year-old girl. And for about 5 years after her mother died, she was in touch with us. हमें Eid cards भेजती थी. She did her A levels, then she went to uni abroad, everything. But that question changed the way I practice, because you can never prepare for what they'll say.
Thank you so much for sharing, and thank you so much for all you do. Okay, you take time before and you rehearse, and then you go and speak with the family. So I think we'll take all of these comments as we move forward and see how can we better understand and describe the values of communication skills. So we can all become better communicators with practice and teaching. Yes. Yeah, it requires effort. So why do we need to
Absolutely.
communicate well? I think we all need to do it more often than we realize. And being a skilled communicator will have a big impact on how families cope with their child's illness. I think it's rewarding when it's done really well, and it becomes stressful if we think and if we are self-aware of what we do, and when it is not done well, it becomes stressful for us. It's satisfying when we do a very good job. And this satisfaction, it really minimizes our burnout when we feel good, because when the patient and the family comes in with the diagnosis of cancer, they are not asking from us to just help them get rid of this cancer. They know we are not Allah and we are not God, right? They want us to be a part of the journey and do our best in whatever we can do in our capacity. So what is the most important for families in communication? I think there's a lot of literature out there, West, and I think new literature from our part of the world is coming out as well. So what the family wants is the facts, clear and understandable information. Even if the information is hard for the family to hear, they still want us to tell the truth. And sometimes as a care provider, I think it's our own fear कि हम डरते हैं, हम परेशान होते हैं, हम अस्यूम कर लेते हैं कि पता नहीं उनको ये बात बुरी लगेगी और या उनको दुख होगा, but we don't know. They already know much more than we do, but they want us to be very honest and transparent with them so that they can feel that they are going through the same thing what they are going through. Honesty and empathy, what they have asked for, responding to their concerns and emotions, discuss what can be done, suggesting realistic goals, and including parents in decision making and patients in decision making. So we all know communication is very, very critical. I think whatever we say, and I think most important, whatever we don't say, they matter most, because your 95 to 97% communication is your non-verbal communication. So I think नहीं समझ में आ रहा तो बोलने की जरूरत नहीं है. Your presence will be as important as your words. So just use your words very wisely, because communication is the procedure of a palliative care clinician. And it's a very famous quote here for Oliver Wendell Holmes. He's a American physician and a poet. He said, speak clearly if you speak at all, carve every word before you let it fall. And how deep is this? And I think everyone has read this book, When Breath Becomes Air. And it was there, when there is no place for the scalpel, words are the surgeon's only tool. So कितनी अहमियत रखते हैं ये अल्फाज. So I think listening, truly listening to your patients, your parents, and to your colleagues matter the most. So what about communication in pediatric oncology? I think it's between patient and family and the oncologist. It's a bedrock of the relationship. And I think our working model for how this relationship should function frames around what kind of communication we do. We have a model of expert model where an oncologist possesses all the information and dispenses to the patient. And there's a consumer model where a patient buys what she requires from the oncologist. However, patient and parent relationship and the physician relationship fundamentally rely on and trust. And this model fosters shared decision making, where an oncologist uses her expertise about cancer, therapy, and the clinical consequences of both to work with patients' individual goals, concerns, and their ideas about well-being. So I don't like the word counseling. It always come to me as a one-way conversation. I like it a discussion. Counseling means you are just telling them what to do. Discussion mean you take their opinion into account and then you come up with the plan together, because it's about them as well. It's not about us as a clinician and a physician. So what are some pitfalls and common barriers to good communication? I'm sure there must be more and we'll come across as we move forward. So maybe giving pathophysiology lectures is a common barrier. Do not use medical jargons, use simple language. Ignoring the context of communication encounter. Not finding out patients' information needs, what they need at that point of time. Launching into your agenda first without negotiating the focus of the interview, or offering reassurance prematurely, that we often do. कि reassure कर दें उनको, because हम खुद परेशान होते हैं, वो तो हमसे कह ही नहीं रहे. So what are some 3 core skills that a physician or a care provider requires to be providing good, effective communication? Active listening, responding with empathy, and use of appropriate silence. So in active listening, letting the other person speak is very important. Don't go in with your agenda. Just interrupt only when there is a need to interrupt. Let them speak. Encourage them to talk, whatever they want to, and look for some hidden questions. There are hidden questions in their conversation, and they give you the lead during the conversation. And active listening gives you the opportunity to look for those hidden questions and ask them, because बात दफा conversation इतनी आगे आ जाती है, you don't want them to go to that point again and talk about that thing that can give them pain, although they are giving you that opportunity to tell me that, am I going to die? And sometimes it's our own fear that we said, नहीं अभी तो चीजें बेहतर हो जाएंगी, और हम दिल में कह रहे हैं जब टाइम आएगा हम बताएंगे. But they're asking you, let me know, so I can plan my life ahead, or I can plan the life of my child ahead. and allow short period of silence so that a person can process and clarify whatever they are thinking and processing their feelings. Number 2 skill was responding with empathy. And we know empathy is an act to imagine yourself in other person's situation. But when we talk about responding, it means you are conveying this understanding to the person that you really understand what they're going through. And articulating that empathy is an art. And how beautiful is this when you can articulate that empathy in a way that I can really imagine कि ये खबर आपके लिए बहुत तकलीफ दे हो सकती है और काश ये सिचुएशन कुछ मुख्तलिफ होती, बट अफसोस इससे ज्यादा हम कुछ कर नहीं सकते और हम इसको ज्यादा जिंदगी नहीं दे सकते, और काश मेरे पास कोई अच्छी खबर होती आपको देने के लिए. मतलब these are simple words and they need us, they need these words from us. And then use of silence, because people often pause before they say something very important, and you can relate with that as well. And it, because the silence allows the person to process feeling, and remaining quiet for a moment, and use your active listening skills so that you can understand. And after a short period of silence, if the person has not spoken, continue to speak, because अगर आपका वो silence लंबा हो जाएगा तो वो conversation का flow खत्म हो जाएगा बिल्कुल. So वो भी एक art है और वो practice है करने के लिए. So what if the parent asks, is my child going to die? So what we can avoid is, do not worry, I'm sure he'll get better. I think ये हमारे दिमाग में आता है क्योंकि हम खुद ready और prepared नहीं होते इस चीज के लिए. But what we can do with practice, I hope that he will, and we are trying all the treatment that we have that may help. But I'm very worried that based on what we are seeing, he's not getting better. And even with all these treatment, यही सच है. उसको उनको ये पता, उस सच के साथ वो हमारे पास diagnosis लेकर आए थे and all. So we also come across, I think जो West में हम सुनते हैं wish, wonder and worry. तो मैं सोची थी उस दिन बैठ के कि ये हम अपने लैंग्वेज में कैसे कर सकते हैं. हम बाहर तो बोल सकते हैं आई विश, आई वंडर एंड आई वरी. तो इसी तरीके से जैसे हम कहते हैं आई विश दैट आई वुड हैव वांटेड थिंग्स टू बी डिफरेंट, बट मुझे अफसोस है और मुझे ये खौफ है कि ये चीजें वैसी नहीं हो सकती, बिकॉज वो बीमार से बीमार होते जा रहा है और मुझे लगता है कि वो बेहतर नहीं हो पाएगा. एंड देन आई वंडर, और मैं सोचती हूँ दैट के आपको इस बारे में बात करनी है. अगर चीजें बेहतर नहीं होंगी, आपके जहन में और क्या ऑल्टरनेट है कि हम उसके लिए क्या कर सकते हैं, क्योंकि हमारे लिए वो जरूरी है जो आपके लिए जरूरी है. So what to say and what to avoid? What would you like us to do for your child? I think we should not say that, because we are not giving them the menu to choose an option from them. What we can do is that what is important for you, knowing that आपका बच्चा बहुत बीमार है. So there are some helpful phrases that we can practice, like exploring. Tell me what you understand about your child illness, because your conversation always start that what's the understanding of other person. Maybe आप जो सोच रहे हैं वो वहाँ पे अभी मौजूद ही नहीं है. And then asking the permission, that would it be okay for me to discuss what we have learned from the medical tests with you right now? Maybe they're not उस स्टेट में ही नहीं मौजूद है. Maybe they need some other person to be with them so that they can process that conversation, and giving them a warning shot and a heads up, like, I'm sorry to say that I have some bad news. The tumor has grown, the cancer is getting worse despite our best treatment. So clear a statement for them. So these are 3 fundamental skills that are being used, and that we use in our conversation, is like asking from them, just tell me more. What is the understanding? What you're not sure, that when you're not sure that when someone is what someone is talking about. And then doing the ask, tell and ask thing. And then your I wish statement, responding with empathy. And I think that fits well in all the conversation. So what about talking to children? I think that's the thing you discussed about, and I think that's very, very challenging. And I think culture has a role to play in this as well. And I sometimes feel like I may be wrong, that sometimes we blame our culture for this. Culture भी तो हम ही बनाते हैं ना. And क्योंकि ठीक है, the culture means you approach the family the way they live or their culture is, but you need to make them aware of what is actually happening. They need to know in an age appropriate manner. So children communicate in 3 ways: verbal, non-verbal, and play. All this need is to spend time with them, getting to know them before, how they are as a boy, how is he as a boy, how is he as a girl, building a rapport that will help you in getting there and having a conversation with them. Not about, not just for to tell them that what they are going through, what is their diagnosis, but to let them process what they are feeling. They are human. Their body is suffering from cancer. They need that thing. They need that. I think they need this. I would say that उसके लिए क्या लफ्ज होगा? Decency. I think to hear about that what is happening with them, but without not without disrespecting their parents. I think with the permission of their parents, taking parents their opinions into account, and then speaking with kids. So talking to children about their illnesses, I think start by providing emotional support and coping, and then establishing a culture of openness. And how you can establish a culture, like building a good rapport with them, and then discussing benefits of disclosure with parents, that exploring their family fears about disclosure. Bhai, aisa kya hua tha? Agar teenager hai, I think that teenager needs to know what's happening. I have seen one of the 18-year-old with osteosarcoma dying, and I would say कि 18 साल के बच्चे को पता होगा, and the mother standing there right at the bedside was saying उस बच्चे को कि तुम ठीक हो जाओगे. और जब वो कहती थी तुम ठीक हो जाओगे, I don't know उसके अंदर वो क्या रश आता था बच्चे के अंदर कि वो जिसको हम मॉर्फिन और मिडा दे रहे थे कि ये क्या कह रही हैं. So there is always a sense of mutual pretense, जिसको हम कहते हैं कि एक पार्टी को भी पता है, दूसरी पार्टी को पता है, बट दोनों आपस में बात नहीं करें. वो उनकी मोहब्बत में बात नहीं करे, वो उसकी मोहब्बत में बात नहीं करे. But the teenager needs to know what's happening. So how do you answer the question like, am I going to get better? So वही हम rehearse करके जाएंगे और हमें पता हो कि क्या क्या सवालात आ सकते हैं. So well, you could say that always ask from exploring the other person's thoughts, that तुम्हारे जहन में ये बात क्यों आई? मैं जानना चाहती हूँ, ये जानना चाहता हूँ तुम्हारे लिए ये चीज जरूरी क्यों है? तुमने ये क्यों पूछा? वो आपसे ये कह ही नहीं रहा, मुझे बता दो. मालूम तो करें, हो सकता है वो उस जगह पे हो ही ना, क्योंकि हम एडल्ट है ना, हम सबसे पहले आखिरी चीज पे पहुंच जाते हैं. हम कब्रिस्तान तक भी पहुंच जाएंगे उस बच्चे को लेके. वो तो अभी यहीं बैठा हुआ है, वो अपनी पिकलाइन के बारे में सवाल पूछता है. So what do you think? We can also say that I can tell that you have been thinking about it. So what do you think? Or what are you worried about? So what not to say? We will have to wait and see. So don't just brush them off by saying that, okay, we will have to wait and see, because they give you the lead in your conversation, and just follow that lead. And how can you follow that lead? When you are actively listening and actively a part of that conversation. और आप जब होते हैं, आपको बहुत सारी चीजें ऐसी सुनाई देती हैं जो वो बोल भी नहीं रहे होते हैं, and you can figure out नॉन वर्बल तौर पे भी कि वो क्या चाह रहे हैं यहाँ पे. So using words that the child will understand through drawing picture and play therapy. I think we are slowly getting there, slowly. And one explanation may not be enough. So do not assume that the child understands after one conversation, and just be honest. Do not lie. पकड़ लेते हैं वो. 8 साल का भी बच्चा होगा, वो पकड़ लेगा. ये तो तजुर्बा मैंने देख लिया है. So do not lie. Explore and tell them this. I think the other day there was a 10-year-old and he said, मैं बोन मैरो नहीं कराऊंगा. भाई क्यों नहीं कराओगे? इतनी बड़ी नीडल से आप करेंगी, मैं तो नहीं कराऊंगा. हम उनको ट्रीटमेंट रूम में ले गए. हमने कहा तुम्हें नीडल दिखाते हैं. जब उसने नीडल देखी, उसने कहा अच्छा ये तो बहुत छोटी नीडल है. हमने कहा, फिर वो आया नेक्स्ट स्टेप पे, लेट के नहीं कराऊंगा, आप मुझे सुला देंगे. तो हमने कहा तुम बैठ के कराओगे तो तुम्हें दर्द होगी. तो कह लेंगे अच्छा फिर कैसे लिटाएंगी और कितनी देर. सो सी वी वर रिस्पॉन्डिंग टू हिज क्वेश्चन, और वो ही वाज गेटिंग देयर, आराम से बोन मैरो हो गया. तो दैट हैड रिड्यूस्ड his anxiety, his parents' anxiety, and I think our anxiety as well. हम भी तो कहीं ना कहीं सफर हो रहे हैं ना. So benefits of disclosure to the child are it decreases isolation and feeling of abandonment. creates more control and less anxiety. And I think give child an opportunity to prioritize their time and complete some important task. And I think that goes same for parents and families as well. So misguided objection क्या है? Fear of inducing anxiety. पता नहीं कहीं हम anxiety induce ना कर दें. Or perception that children cannot understand the truth. ऐसा कुछ भी नहीं है. And perception that some children do not wish to know the truth. So practice will make all of us better at this. That what are you worried about? Sometimes no matter how hard everyone tries, our body cannot be fixed. No one knows for sure, but what do you think? And sounds like you want to talk about what might happen if you cannot get better. Do you? So what about hope after talking to the child? If we disclose to the child, won't they lose their hope and die? सबसे पहले ये सवाल माँ बाप के जहन में आता है और बाद में हमारे जहन में आता है. So it's there that communicating honest information about prognosis does not take away home. And what advice we can give to parents is encourage children to ask questions. Help them ask questions. Share your grief with your child so your child is comfortable in sharing his or hers with you. Reassure child that the feeling of grief are normal and everyone grieves differently. And encourage child to express himself through words, drawing or play. Just create an environment, safe environment for children. वो कब होगी? जब हम खुद उसमें safe महसूस करेंगे. जब हमें लगेगा उससे कुछ नहीं होगा. मतलब हम का मतलब ये उनके parents or maybe as a care provider. So moving on to the challenging part of our practice is like breaking bad news right, left, and center. Whether it's about new diagnosis, recurrence of disease, disease progression, failure of therapy, result of any genetic test, communicating prognosis, and court status. So what is bad news? Any information which adversely and seriously affects an individual views of his or her future, or any information that is not welcome, or an uncomfortable experience for both the giver and the receiver. So what are some challenges and advantages from the patient perspective? Like often have vivid memories of the bad news, or negative experience can have a lasting effect on anxiety and depression, or in a positive way that can facilitate adaptation to illness. And what are the challenges from the physician or the care provider standpoint? Fears of being blamed, causing pain to the family, upsetting the family and the patient, inciting an emotional reaction, or maybe the challenge is we don't have time. We are seeing so many patients, we cannot spend time. And everybody is busy, of course. We have a lot of burden of patients, or lack of training in delivering these news to the families, or some culture constraints or language barriers. So why should it be done? Because it serves as the foundation for many of the essential goals of pediatric oncology. It helps develop shared knowledge and creating a relationship of mutual caring and respect and trust. And it works towards supportive shared decision-making between child, family, and a clinician. And that's a skill that can be taught and improved with practice. So what do patients want for themselves? From us, for more time to talk and to express their emotion and feeling. That's all there in the literature. And from a physician, more info, more confidence, and hope, and a familiar face. And familiar face कब होता है? जब आपकी rapport building होती है, वो आपका face खुद ब खुद उनके लिए familiar बन जाता है. हमें भी किसी अजनबी से कोई बात अच्छी नहीं लगती, खास तौर पे जो हमारी personal बात हो. So we all know the famous model for using and breaking bad news is like spikes, starting from setting a space, secure space. You don't have to block a room or sofa or tissue paper and everything. It's ideal when we can do this, but in an R setting, we cannot make an ideal scenario. Just maybe a corner, giving them sense of like security and privacy can help and go a long way. And then perception, that always get information from the family before you give information. देखिए आपको कहाँ तक पता है, आप क्या जानते हैं कि बच्चे के साथ क्या हो रहा है, या आपके जो प्राइमरी डॉक्टर हैं उनकी बात कितनी समझ में आती है आपको, वो क्या कहते हैं आपसे. And then invite, ask permission to tell more. Can I tell you more about what's happening and how much information, what's likely to happen would you like from me right now at this point of time. And then give them all facts by avoiding medical jargons and give information in small pieces. Because हम तो बोल देंगे for the sake of delivering information, भाई हो गया काम, आज के राउंड में हमने बता दिया. क्या उन्होंने प्रोसेस कर ली? No. They need info. Maybe वो आप जिस एजेंडा के साथ जाएं वो एजेंडा पूरा ही ना हो, क्योंकि they were not ready to do that. Maybe आप स्पाइक के एस पे आके खत्म हो जाएं, वो इतना रोना शुरू हो जाएं, तो सेट पी आई के ई एस तो हम कल करेंगे. And that's all okay, because it's about their child, his life. It's not about us. They're doing the round and completing this task and then moving on. And then check understanding frequently कि आपके कोई सवाल तो नहीं है. And then with empathy and emotion, that stop talking, listen and observing for emotion, naming their emotions. And this is how you can articulate empathy. It's a mnemonic use, nurse. You can name the emotion by saying, I see that you are experiencing a lot of emotions. You understand there's a lot to be dealing with. This seems very difficult for you right now. Respecting what's happening. You're good, loving parents. And I think you're doing absolutely the best a good parent could do. Supporting that I'm available when you have questions. No matter what you decide, we'll keep helping you and your child. And then exploring more. Okay, what are they thinking? Is there anything that they need to hear from us or get self-support? So I think the most important thing in communication is the cultural sensitivity as well. That how do you adapt your communication for diverse families? And anyone can share an experience where culture differences impacted that communication scenario. Is there anyone in the hall that had come across that the cultural barrier in their communication? So I think these are the pertinent points that help overcoming this sensitive is like listening and understanding the importance of active listening and asking open-ended questions so that you get to know that how's the family like and what are their cultural beliefs, and being flexible in our communication based on the family preferences. That helps building the trust and rapport with the family, and respecting and encouraging sharing how respecting cultural practices can facilitate better communication. It doesn't mean that you keep the information from them. That's not cultural sensitivity. Cultural sensitivity is that how you approach with the information to that family. Maybe they want indirect communication. They need more family members. That's another family. One is a nuclear family. Dad needs to hear the news by himself. There's a family that dada, dadi, nani, that's cultural sensitivity. Keeping the information is not cultural sensitive from them. So I'm skipping that case scenario. ये बहुत बड़ा है और वो डाल दिया था. So these are my references. But अभी तो हमारे time है ना? Okay. So I have a case. I think काफी लोग आ गए. कितने लोग हैं? हाँ. So are we taking question अभी या बाद में? क्योंकि हम ये case कर लें या we can
So we'll take the questions once you finish with your role play.
Okay, perfect. So we'll complete it. So I think हम काफी लोग आ गए हैं. अगर हम चार के ग्रुप में बना लें अपना 4 का ग्रुप. So let's do a quick case thing and just we'll ask one of the group to come and present, and then we can talk about the feedback on that communication. So I'm just चार के line में आप एक साथ दीजिए. सर आप आगे आइए. पेपर खाली आ रहा है. हाँ, ओके. ले लें. पेशेंट 3 कर लें. 4 हो जाएंगे तो 3 people I think. हाँ. नहीं होता है.
Each group chooses one member to role play their scenario with the rest of the group. Role play expression. Execution. Each is 3 to 4 minute role play, followed by the 2-3 minutes of feedback from the server. 2 से 3 से 4 मिनट हमने ये रोल प्ले करना है. ठीक है. और 2 से 3 मिनट में इसका फीडबैक हमने ऑब्जर्वर से लिया. ठीक है. ये एक्टिविटी ये scenario क्या है? You are a physician, आप care provider हैं, and this patient was referred to you. एक patient आपको दिया है.
सही चल रहा है ना टाइम पे? टाइम मैंने सुबह टाइमर पे बैठ के टाइम किया अपने आप को, देखिए रिस्पेक्टिंग टाइम ना। हाँ। I think we are ready. So anyone? हाँ. So किसी ग्रुप को वॉलंटियर करना है या मैं खुद पिक एंड चूज दोबारा कर लूं? नहीं नहीं, आप लोग हमेशा कर रहे, नहीं 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 नहीं, मुझे ये नहीं ग्रुप चाहिए, नहीं सब करना चाहते हैं। तो एक काम करते हैं, हर ग्रुप में से मैं एक उठा लेती हूँ, एक पिक कर लेती हूँ। हालांकि 4 लोग ही चाहिए, मैं 3 लोग चाहिए। आप में से कौन कोई एक आ जाएगा? आपने प्रैक्टिस की हुई है ना सबने? आई थिंक आई वुड लाइक जो लास्ट वाला ग्रुप है, आप जो चारों हैं, आप आ जाओ। हाँ ना, आप आ जाए। तीन दो तो और चाहिए होंगे मेरे ख्याल से। एक को हम साइलेंट ऑब्जर्वर बना देंगे। आप इधर बैठने, आपने आगे ये ओपी का आपके ऊपर रोल ना करे, आप बैठे रहने। मेरी डॉक्टर आजम को बच्चा बनाए थे, आ जाए। वो क्यों बैठ गए भाई? नहीं तो 3 लोग चाहिए हमें। तो जो आपने प्रैक्टिस की आपस के अंदर, ग्रुप के अंदर, सो एक मदर हो गई, एक डॉक्टर हो गई, ये आमना हो गई, आमना हो गई, एक और आ जाए।
We need a 14-year-old girl.
वो बैठे हैं 14 ईयर ओल्ड, वो उन्होंने सबसे पहले। अच्छा, आप अपना नाम बता दें। एक देखिए, लग रहा है ये पीडियाट्रिक पैलिएटिव केयर का सेशन देखिए। हाँ, इसको पास कर लेते करा दें अपने आप को, और आप क्या रोल प्ले करें ये भी बता दें, और फिर एक बंदे ना पूरा सिनेरियो जल्दी से पढ़ लें।
ठीक है, मेरा नाम इरफाना है, मैं एज अ मदर रोल प्ले कर रही हूँ।
So I am the palliative care physician for the mother.
और अब पीडियाट्रिक ऑन्कोलॉजिस्ट।
Okay. My name is Aksa Safdar. I am MPhil pharmacology and मैं रोल प्ले कर रही हूँ गर्ल का। Okay? गर्ल का पेशेंट नहीं, अच्छा पेशेंट आप हैं, अच्छा फोर्थ रोल, अच्छा फिर मैं क्या बनूँ? ऑब्जर्वर, ठीक है मैं ऑब्जर्वर हूँ।
मैं आमना हूँ।
आमना को कीमोथेरेपी के साइड इफेक्ट हुए।
So the scenario, I think everyone has it. Amna is a 14-year.
बीमारी की नहीं। No, serious.
So Amna is a 14-year-old girl diagnosed with osteosarcoma right thigh in 2021. She underwent amputation and chemotherapy, and NGO was able to give her prosthetic leg, which made her very happy because she was a TikToker before. Patient apparently was asymptomatic for some months and had even enrolled herself in the school for online classes. She is an A-list student, and 1 month prior, she began episodes of dry cough and then began to have shortness of breath. A CT chest scan was done yesterday, which showed lung metastasis along with bone metastasis on a bone scan. The oncologist feel that she is no longer fit for the chemotherapy as the cancer had spread more and advanced. The mother is so worried. So the doctor has to counsel the mother and the girl about this diagnosis and a further plan. So she is the mother. She will ask.
अस्सलाम वालेकुम डॉक्टर साहिबा।
Walaikum assalam.
डॉक्टर साहिबा, मेरी बेटी आमना, आपको पता है आपके पास उसने ट्रीटमेंट लिया है और अभी ये बिल्कुल ठीक ठाक थी और नॉर्मल एक स्कूल भी जा रही थी और नॉर्मल बिल्कुल खुश थी। लेकिन कल इसको ये हुआ है कि कल ये जब स्कूल से वापस आई है तो इसको एकदम खांसी और चलने में तकलीफ हुई है। तो इससे पहले वो बिल्कुल ठीक थी और हम खुश थे कि इसका ट्रीटमेंट खत्म हो गया है और ये एक नॉर्मल और एक इंजॉय कर रही थी अपनी लाइफ को और ऐसा टिकटॉकर ये बहुत ज़्यादा खुश थी। तो अब ये है कि आमना को ये मसला हुआ है तो हमने अब सीटी स्कैन कराया है और देखना चाह रहे हैं कि क्या हुआ है इसके। जो यकदम आपने सीटी स्कैन ही क्यों करवा लिया और एक्सरे और इससे पहले क्यों नहीं कराया, क्योंकि इसको खांसी वगैरह तो मौसमी भी हो सकती है।
बिल्कुल ऐसा है, आप बिल्कुल सही कह रही हैं। हमने इसके टेस्ट इसलिए कराए थे कि कोई अगर बीमारी कहीं पे छुपी हुई है तो वो हमें मालूम हो सके। हम आमना से बात करना चाहेंगे। आमना, आप कैसा फील कर रही हैं? आप ठीक हैं?
ये वो हल्की सी खांसी है, वो वैसे खांसी ही है, कुछ खास नहीं है।
कब से आप बिल्कुल ठीक महसूस कर रही हैं? आप ठीक हैं? आप टिकटॉक बना रही हैं? इट्स ओके, इट्स गुड।
लाइव लाइव वो
अच्छा, लाइव टिकटॉक शेयर कर रही हैं। अच्छा, ओके
बेसिकली बस कभी कभी सांस फूल जाता है और कोई
ओके
ओके नहीं होगा कुछ ऐसा।
ओके। आपके कल कुछ स्कैन्स हुए हैं, कुछ सीटी स्कैन्स हुए हैं, आप उनके रिपोर्ट्स के बारे में जानना चाहेंगे अभी?
दादी क्या हो रहा है?
ओके, इधर सामने आ।
नहीं, इसके सामने ना बताएं क्योंकि ये परेशान हो जाएगी।
नहीं मैं बैठा हूँ, बैठी हुई हूँ। मैं बैठी हुई हूँ।
आप जाना चाहेंगे अपनी मदर की मौजूदगी में? आप किसी को बुलाना चाहेंगे?
और किसको बुलाने?
अच्छा,
इसके
ठीक है,
अब
आपके
इस-
फादर को तो नहीं बुला पाएंगे?
कोई वजह है आपको बुलाने?
हाँ, कुछ रिपोर्ट्स में कुछ प्रॉब्लम है जो कि शेयर
क्या
करना
problem है?
चाहिए। मैं आपको बताऊंगी। आप रेडी हैं सुनने के लिए?
मुझे क्या पता, पहले आप बताएं तो वो क्या है, क्या खबर, फिर मैं बताऊंगा।
इट्स
वो
ओके,
क्या
इट्स ओके।
I think time out, time out, time out, time out. चले, आजा इधर आजा मदर। अच्छा, so let's have a let's get some feedback from the audience here. So क्या नोटिस किया आपने कि किस तरह ये क्या ये it was the right way to communicate and to start this conversation with the family? Even Amna was there as well. So what do you all think?
I think engaging Amna more upfront and talking about what she was doing with the camera, what she was sharing, just spending more time with her before getting to the news. I mean, eventually you have to get to it, but I think that's one aspect.
Okay. Anyone?
Like it is imperative to check their understanding of the disease itself. कि आपको पहले क्या बताया हुआ था इस बारे में, थोड़ा सा उसको explore करना चाहिए।
किससे चेक करनी है, आमना से या मदर से?
आमना से भी कर सकते हैं, it's okay, she is sensible.
अच्छा, फिर हम एक ना कोई रोल प्ले कर लेंगे कि ये कैसे बेहतर हो सकता है।
Yeah, I mean, actually, I'll start with what was done well because I thought that the जो physician act कर रहा है, it's very difficult to sit in front of 30 people and do this acting. So, she did a great job. And I would also say that whilst Adil was being aggressive with her, she remained very calm and, kept addressing her points one by one. She didn't become, maybe in a real life conversation, I might not allow my patient to make a TikTok, but she, allowed it and she went on with it and things like that. So, yeah. So before the timeout, actually, I think those were the things that were going very well. She was calm. She was trying to address things. Obviously, जब role play होता है, sometimes it's difficult because I think the mother went on to give too much information prior. So therefore, one thing that I might have done differently is prior to initiation of conversation, try to establish that who needs to be in the room and who does not need to be in the room. And that is something I would have spoken before we started acting out that scenario, because in a real world conversation, that's what I would do at least. I would first speak to the guardian and I would try and establish how much they want the child to know before I go into the room at all, because otherwise you will be in a situation जो हुई कि आमना तुम चली जाओ यहाँ तुम्हें हम नहीं बताएंगे, and आमना saying मुझे तो जानना है. So उसको avoid करने के लिए that's the one thing different that I would have done.
No, I was saying exactly the same thing, that before you bring the child, before you start the consultation with the child, you have to establish with the mother whether Amna needs to be in the consultation and how much information needs to be before the consultation even starts. So with the child, that is something that needs to be established beforehand, especially when you're talking about breaking bad news.
I think Dr. Halima said the right thing. उससे पहले एक step यही था कि establishing that with mother के does she really want Amna to be involved in that conversation, and how much does she already know about her illness and all, which seems like she knows everything and TikToking everything.
I think most of what I wanted to say has been already said. The only thing I would say is that in a conversation like this, you need to have your agenda very clear in your head so that the open-ended part of the conversation doesn't become too wide that you can't control and bring it back. So you need to focus yourself on, to ask that, how are you? Are you well? Then that is a never-ending conversation. So I think jo usko close karna in a timely fashion is an art that you get with experience, and you're actually doing very well, mashallah.
So good job. Do you have something?
No, your time is up. You've got 1 more minute.
नहीं, thank you so much. And I think जो आपने बात की, that practice comes with time. And I think हमें इन चीजों में जल्दी नहीं करनी चाहिए. जब इसमें टाइम वाकई ही लगाना है और जरूरी है टाइम लगाना, हम ये सारी कॉन्वर्सेशन वी कैन नॉट जस्ट डू इट के भाई आपने एक उसमें कर दी कि बताना है जस्ट फॉर द सेक ऑफ letting them know about their progression of disease and all. And क्योंकि मैं हमेशा मेडिकल स्टूडेंट्स को भी कहती हूँ और रेजिडेंट्स को भी कि उन्हें लगता है कि भाई आप बहुत ज्यादा टाइम स्पेंड करना पड़ता है, इतना टाइम तो होता नहीं है. जब हम 3rd ईयर मेडिकल स्टूडेंट होते हैं हमें घंटा लगता था हिस्ट्री लेने के अंदर. अब हम 5 मिनट के अंदर वो पूरी हिस्ट्री लेते हैं कि वो इतना वेल इंटीग्रेट हो गया हमारी प्रैक्टिस के अंदर कि क्या सवाल पूछने क्या नहीं है. तो जब हमें आदत हो जाएगी तो वो हम 5 की अगर 10 मिनट भी लगा लेंगे, लेकिन आप वाकई वो काम कर रहे होंगे जो उन्हें चाहिए इस चीज के लिए और जो उनकी पार्ट ऑफ केयर है. क्योंकि हर केयर को प्रेस्क्रिप्शन पे लिखने की जरूरत नहीं है. हमें लगता है कि जो चीज हमने प्रेस्क्रिप्शन पे लिख दी वही केयर है. तो केयर तो ये है जिस तरह आप बात करें, दैट्स आल्सो केयर. सो या, थैंक यू सो मच.
Okay, Alina, is there any question for Resham? Yes, please, Dr. Shakila, go ahead.
I just, this was very nicely done, Shazati, but I just wanted to ask you, because role playing is good, but if you're really training your fellows, residents and all, I think using standardized patients or what we call actors actually has a much better impact. और हमारे पाकिस्तानी ड्रामा में तो बड़े अच्छी एक्टिंग होती है, तो you could utilize scenarios. I don't know if Sadaf is there, but she did a fellowship with me, with us, and we had a simulation center, and where we did, like with the first year fellow, we did how to talk to a patient about a new diagnosis. The second year dealt with relapse, and the third year dealt with, end of life care. So you'll be surprised how real it seemed to them with those people which were not colleagues, but were actors and, what we call standardized patients. They know how to really act well. And I thought that really works very well for training. So I just wanted to make that comment about the training part of how to convey bad news. And we did it with every year with our fellows in the 3 years.
Thank you so much, Dr. Shakila. And I think you're absolutely right. ये तो अभी हमने role play यहाँ for the sake of just engaging our audience किया, but you're right. We do have simulated parents जिनको हम train करते हैं and to be a part of that conversation. But of course, we are not there yet. अभी proper 100% तरीके से नहीं हो पा रहा. But I think that's the right way to do. And that the SPs hote hain and all, they should be given a script, they should be well trained, and when to stop, when to use silence, what's the body language
Exactly.
they are going to use, so that you can give the trainee the real feel of what's happening, what really happens in the field. So, and yeah, bilkul, you're right. Thank you.
Acha, right. So
So
that
one
is
quick
definitely
question.
there. एक और सवाल है मेरा,
जी, Dr. Shaukat.
क्योंकि यहाँ पर तो it's much easier to do, but when I have people from Middle East या पाकिस्तान या India, हमेशा ये होता था कि बच्चे को ना बताएं. So how I think the culture seems to have changed. कि वो they're more open there now, which is I'm happy about that, because वरना ये होता था कि how can you not tell the child when they are going to go through treatment and everything कि कुछ कह दें कि बस यूं है या you know chemotherapy
Dr.
है, side effects होंगे. So how do you deal with that?
Yeah. So Dr. Maz wants to respond to that, and I'll do that after.
So I'm working in the Middle East at the moment in Qatar.
I can't hear you.
Sorry, this is Maz, and I'm a pediatric oncologist. I work in Qatar at the moment. Can you hear me now?
इधर आ जाए. Dr. Shakila, एक second. आप फिर बताइएगा if you can hear us.
Okay.
Can you hear me now?
Yes, I can hear you now. Thank you.
So my name is Maz. I'm working in Qatar at the moment. I'm a pediatric oncologist.
I think I've met you before. So
We have indeed. Thank you. So I think that cultural attitude is very much there. I tell you, there are families who do not allow us in a very express way. They refuse to give the diagnosis to 12, 13 years olds, and they
Right.
know fully well that the child also knows, but they wouldn't want it acknowledged between them. And
Right.
actually, sometimes to the extent that the dad doesn't want the mother to for them to have this conversation that this is cancer we're dealing with. We come to the
Right.
oncology ward every 3 weeks for this course of some medicines, which cannot be called chemotherapy because chemotherapy is cancer. So
Right.
that kind of attitude does exist, but inroads are being made. And
Good.
there are more and more people who are open to it, but the challenges do exist still.
Yeah, that's
I
what I
think-
noticed too.
And I think same goes for us here in Pakistan as well. Of course, it's not 100% कि आपको allow किया जाए या parents are willing to share these information with kids. But sometimes they do allow you, sometimes you need to find out those opportunity. And sometimes, of course, many of the time you respect how do they want it to be with their kids. But I don't know, maybe slowly we'll get there. It needs awareness and you want to respond?
So sorry, I'm going to interrupt. So we have to end the session now. Thank you very much, Dr. Resham, and thank you very much the audience as well as our online for such an interesting and interactive session. And I'm sure we can go on throughout the day discussing this.
Yeah.
So I will now go to our next
Thank you so
talk.
much for
Thank
the
you, Resham.
opportunity.
So our next speaker is Dr. Harun Hafiz, who's a graduate of Buckeye Medical College, and he has done his diploma in palliative medicine and FRCP from the UK. He has played a pivotal role in developing palliative care services in Pakistan and has been instrumental in developing the palliative care fellowship, which is being recognized by the CPSP. He's also the first supervisor of the country for the palliative care medicine. Currently, he's working as director for Quality Patient Safety Department and a consultant hospitalist palliative care physician at Shaukat Khanum. His talk is going to be end of life care.
एरो से चलेगी ठीक है जी अस्सलाम वालेकुम everybody. It's going to be difficult to follow such a lively talk with this topic. Actually my heart sank when they asked me to speak about it because end of life, and then when we talk of end of life in children, it's something very unnatural and no one wants to talk about it. But it's something that very much happens, and it's something that we need to acknowledge. Just by shying away from talking about it, it's not going to change anything. So I'm going to try and make it sound as practical and as pragmatic as it's going to be, because if you don't do that, then you really can't live with yourself, because you know, it's nice to be empathic. It's nice to be you know, sharing the concerns and feeling what the trying to feel what the family is feeling. But if you keep doing that every day, you're going to burn out very soon. So when you are faced with this, in the interest of your own patients, their families, as well as in your own health's interest, it's best to be as practical and pragmatic around this issue as you can be. But it's always very tough. जैसे अभी पहले discussion हो रही थी, तो मैंने यही बात की थी कि, you know, after 15, 18 years of doing palliative care and looking after the pediatric palliative care side of things as well at Shaukat Khanum, I still sit in my office and rehearse if I have to go and talk to a child's parent or to a child even about, you know, because this is not about, when I get involved, this is not just about discussion around prognosis or diagnosis. This is always a discussion mostly around something bad. And before I start, मैं एक वाकया आपको सुना देता हूँ कि I was walking in the corridor of Shaukat Khanum once, and sometimes people know the name but they don't know the face. तो दो लोग आपस में बात कर रही थी माएं, and I was standing just checking my phone because मेरा clinic room अभी खाली नहीं था. तो वो माँ दूसरी माँ को तसल्ली दे रही थी कि तुम्हारे बच्चे का कैंसर ठीक हो जाएगा, मुझे 6 महीने हो गए यहाँ इलाज कराते हुए, अभी तुम्हें कौन से डॉक्टर को भेजा है? उसने कहा सो एंड कॉलेज के पास भेजा है. हाँ वो तो बहुत अच्छे हैं, ये है वो, मैं नाम नहीं ले रहा, ऐसी मुंह पे तारीफ हो जाएगी, वो ऑन्कोलॉजिस्ट यहीं बैठी हैं. तो सो देयरफॉर ये सारी बात करके उनका बस तुम ये दुआ करो कि तुम्हें कहीं डॉक्टर हारून के क्लिनिक में कभी ना भेजें. उसने कहा क्यों? उसने कहा उनके क्लिनिक में भेजने का मतलब है कि अब आपका इलाज खत्म हो गया है और अब आपका कुछ नहीं हो सकता और आपके बच्चा का हो सकता है. तो हम भी अब आए थे, हमें भी ये किसी ने बताया था, तो हमारे को बता देते हैं कि बस दिन रात दुआ करो कि डॉक्टर हारून के क्लिनिक में तुम्हें कोई ना भेजे. So that's how things get associated. And in fact, जब मैं ये talk बना रहा था, I also work in quality assurance, which is a very lively group in Shaukat Khanum, at least, of very young, dynamic people. So one of the girls who was helping me set up animation actually had tears in her eyes after just reading the talk. Although I tried my best कि मैं अपनी talk में कोई भी ऐसी चीज ना लिखूं, but you know, when she was saying, she said कि sir आप कैसे कर लेते हैं ये? How do you do this? I said, well, someone has to do it. If we don't do it, then all these people will suffer. And that was one of the primary reasons I actually started palliative care in Shaukat Khanum, because I used to work initially as the ER physician, and these patients used to come to ER and nobody would own them because उनका इलाज खत्म हो गया होता था. एक ER visit में उन्हें ट्रेमाडोल मिलती थी, अगले में मॉर्फिन मिलती थी, तीसरे में फेंटानिल मिलती थी. So there was no consistency in care. I think what is palliative medicine, इस पे बहुत ज़्यादा देर बहस करने का कोई फायदा नहीं है. Most of you who are here have an idea of what palliative medicine is about. We'll talk about what good end of life care is and whether any end of life can be good or not. What are the challenges in Pakistan? And then going on to the definition of palliative care, I think जो मैंने सिर्फ चीजें highlight की हैं, उन पे थोड़ा सा focus कर लें कि आज भी हमारे मुल्क में बहुत बड़ा प्रॉब्लम है. शौकत खानम हैज हैड अ पैलिएटिव केयर सर्विस सिंस 2010, फॉर्मल पैलिएटिव केयर सर्विस. वैसे तो 2008 से है, but to 2010 से we have a formal palliative care service with an inpatient palliative care service. And just last quarter's data showed me that 31% of all referrals to palliative care in Shaukat Khanum were within 24 hours of death, which is very sad. And you know, I feel कि 14 साल इस काम को करने के बावजूद we have a huge patient list. ऐसा नहीं है हमारे clinics overbooked हैं and everything. We are 4 physicians now, started with only me, but across the trust we are 4 physicians, but still 31% of all referrals were within 24 hours of death. And that speaks volumes for where we are, even in an organization जहाँ पे इतना ज्यादा पैलिएटिव केयर है कि आप अगर इस कॉन्फ्रेंस में देखें तो 2 पीडियाट्रिक पैलिएटिव केयर के सेशन है, एक पैलिएटिव मेडिसिन का अलग सेशन था. द रिकग्निशन इज देयर, द आइडेंटिफिकेशन की ये एक चीज है जिसको करना है, येट दिस इज वेयर वी स्टैंड. सो व्हाट इज डेथ? हाउ मेनी ऑफ यू बिलीव कि डेथ पैथोलॉजी है या फिजियोलॉजी है? इज डेथ द नॉर्मल कोर्स ऑफ लाइफ? कुल्लु नफ्सन जायकतुल मौत, रिलीजियस पे भी आ जाएं अगर हम, राइट? सो इज इट समथिंग वी कैन अवॉइड? Is it something we can avoid? Or is it something that we have to live with? and Richard Gere का बड़ा अच्छा वो है कि none of us is getting out of here alive, so we might as well enjoy the ride. In an interview, he said. So, is anybody here who thinks that he's going to get out of here alive? Not this room. I hope everybody gets out of this room alive. But so we all know that death is natural. It's going to happen. There's nothing denying it. But now I go to the next question, and by show of hands, आप में से कोई ऐसा है जो ये मानता है कि उसको डेथ नहीं आएगी कभी भी? कोई भी नहीं। आप में से कितने लोग हैं जिन्होंने एक विल बना ली है अपने अफेयर्स की कि अगर आज वापसी पे एक्सीडेंट हो जाए जायदाद किसको मिलेगी, कुर्सी किसको मिलेगी? so hardly 10% people or 15% people raise their hand. So that again speaks volumes. We all know this is going to happen, yet we are not going to prepare for it. अगर हम religious aspect की भी बात करें, so the religion expects us to do that as well. And there is a saying, I don't know अब ये कोई बहुत वो वली की saying है या क्या है, but at least मैंने recently पढ़ी है, वो उम्र शुम्र पे जाने से पहले मैं कुछ दीनी किताबें पढ़ रहा था, तो मैंने recently पढ़ी है कि हर नमाज ऐसे पढ़ो कि ये आपकी आखिरी नमाज है. So, and that's a fact. वो जो बच्चे पेशावर में स्कूल गए थे, I go a lot to Peshawar for Shaukat Khanum Peshawar. I know so many families personally who were affected by it just because I go there twice a month for the last 10 years. And आप उनका दुख कोई समझ ही नहीं सकता कि उन्होंने सुबह बच्चे को स्कूल तैयार करके भेजा है, किसी ने डांट के भेजा कि तुम पढ़ते नहीं हो, मैं तुम्हें ये करूंगा. And imagine the guilt they have to live with कि जिस बच्चे को डांट के उसने स्कूल उतारा था, उस बच्चे की लाश वो वापस घर लेके आए थे. So, this is going to happen. It is something that will happen, yet we don't want to prepare for it. Religious aspect, इससे ज़्यादा तो कोई भी नहीं है कि we all believe कि कुल्लू नफ्सन ज़ायक़तुल मौत. There's no argument around it. क्या death में कुछ अच्छा भी हो सकता है? That is a question I want you to park in your thoughts. Because देखें, एक बहुत ही rude saying है जो मैं यहाँ नहीं बोलूँगा, अगर किसी ने सुननी होगी तो वो मेरे से बाद में बेशक सुन ले. लेकिन अगर कोई चीज होनी है, you can't avoid it. So you need to make the best of that situation. That's what I believe in my life. And there's a saying जो कुछ लोग बाइबल से एसोसिएट करते हैं और कुछ लोग इसे एक फिलॉसफी की saying कहते हैं. बाइबल itself में मुझे ये नहीं मिली, but it's a wonderful saying कि God give me the courage to change things I can change, the serenity to accept things I cannot change, and the wisdom to differentiate between the two. I cannot change the fact that I'm going to die one day. So I have to accept it that I will die. Everything is temporary. So all I can do is try and make it as less painful for, जब आप मर जाते हैं तो it doesn't affect you because आप तो मर जाते हैं. It affects the people left behind. So what you can do is actually try and make it as less painful for the people who are left behind, isn't it? And as caregivers, what we can do is try and make it as less painful for the person who's going through the trajectory and as less painful as possible for the people who are left behind, isn't it? So I'm not going to talk about palliative medicine, but I'm going to now focus on what is a good death. So the first thing that we should all agree, I'm sure nobody will disagree with it, कि dying without symptoms, none of us, मरना तो सब नहीं है, but would anybody want to die in pain? That's the first thing that comes to at least my mind. If I think of my death, I would want it to just happen peacefully. जाना तो है ही, सोते सोते चले जाएं, एकदम से कोई यहाँ पे गोली मार दे के खत्म हो जाए सब कुछ, don't feel anything. You don't want to suffer and then die, isn't it? What else can be good about death? Excellent. So that's what we would want, isn't it? Would we want to die in a hospital room surrounded by doctors and nurses with a catheter in the bladder and an NG tube and 5 IV lines and a central line? ठीक है, अगर खुदा ना करे कोई ऐसी acute illness चल रही है, कोई trauma है जिसमें बचने का chance है, I would want to have all of that done for me. But if there's something which is inevitable, I know it's progressive disease is going to happen, do I want to die like that? I'd rather die with some loved ones around me, peacefully without symptoms. ये दो चीजें बड़ी अहम हो जाएंगी ना. And then I would want to die in my chosen place. मैं अपने, आई डोंट नो, मैं तो अगर अपने घर से, आज तो मुझे काम के सिलसिले में बहुत जाना पड़ता है, बट एवरी टाइम मैं 5-7 रातें पेशावर गुजार के वापस आता हूँ, आई जस्ट चेरिश माई बेडरूम, माई बेड, माई ड्रॉर ऑन द बेड साइड, जिसमें मैंने अपनी चीजें रखी होती हैं, जिस फील के वो हो पता नहीं आज क्या हो गया, आई एम वेरी एट पीस. तो probably at that time I would want to be at a place like that rather than an unfamiliar place, isn't it? तो ये चंद चीजें हैं जो हमें सोचनी चाहिए कि जब हमारा मरीज उस तरफ जा रहा है तो ये चीजें कब होंगी? ये तभी होंगी ना जब हम उससे फ्रैंकली ये बात करेंगे कि चीजें उस तरफ जा रही हैं. अगर हम यही कहते रहेंगे कि नहीं 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 अभी तो वो एक वो नहीं वो एक चीज आई है, मैंने वो भी ट्राई करनी है और आप फिक्र नहीं करें, या हम उससे झूठ बोलते रहेंगे कि सब कुछ बेहतर हो रहा है, तो ये सब कुछ नहीं हो सकेगा. चाहे बच्चा हो चाहे बड़ा हो, everybody has unresolved issues, fears that need to be addressed, and therefore we need to try and resolve those issues before we go. और इस पे मैं 2-3 चीजें आपको कहूंगा. अभी आपने बात की about children and knowing their, one of the children that I dealt with, he was a 10-year-old girl and she was a very intelligent girl, mashallah, and she used to draw lovely paintings. और उसने मुझे ईद कार्ड बना के दिया था, and रमजान के दिन थे, and she was about to, she knew we had had those conversations, थोड़ी बहुत उसको भी अंदाजा था कि things are not looking good, and वो ईद कार्ड उसने 2 मुझे बना के दिए थे छोटी ईद के ऊपर. एक ईद कार्ड पे उसने अपनी फैमिली को बनाया हुआ था, कमरे में टेबल पे बैठे हुए हैं और ऊपर सूरज है, एंड उसने कहा था डॉक्टर हारून ये आपके लिए है, इस पे ईद मुबारक लिखा है. और दूसरे ईद कार्ड में उसकी फैमिली बैठी थी और वो 3 बहन भाई थे, तो वो 2 ही थे. तो मैंने कहा ये तो 2 हैं, तुम कहाँ हो? वो दोनों भाई बनाए हुए थे, उसने अपने लंबे बाल नहीं बनाए हुए थे. मैंने कहा तुम कहाँ हो? उसने कहा आपने देखा नहीं वो सूरज में मैंने एक चेहरा बनाया हुआ है. मैंने कहा हाँ. कि तो मैं मर जाऊंगी ना, बड़ी ईद तक तो मैं जिंदा नहीं होंगी, तो फिर मैं ऊपर से देख रही होंगी ईद पे. एंड आई had gone that day to discuss with her, things are not looking good, we may need to sedate you because you are in so much pain. And उसने पहले से ही मेरी conversation बहुत आसान कर दी कि she was ready. She had drawn that picture to tell me कि मैं I am ready, please let's proceed. So हम सोचते हैं कि बच्चे जानते नहीं है, बच्चे समझते हैं, बच्चे सब कुछ बहुत अच्छी तरह जानते हैं. एक छोटा सा 6 महीने का भी जो बच्चा होता है ना, माएँ कहती है कि वो समझता है बच्चे को कौन किस हाथ से पकड़ रहा है. हर माँ का ये ख्याल होता है नानी बड़े प्यार से पकड़ती है, दादी जरा सख्त हाथ से पकड़ती है, लेकिन फैक्ट है कि बच्चे पहचानते हैं कि कौन उनको किस नजर से देख रहा है. एंड देयरफॉर चिल्ड्रन आर एक्चुअली अवेयर ऑफ दिस, व्हाट्स हैपनिंग. नाउ कम्स दिस, डू आई वांट टू नो व्हेन आई विल डाई? आई डोंट वांट टू नो टुडे. And I'm sure all of you will agree. Does any of you want to know? Nahi na? Because there's nothing, we know that death honi hai, but there's nothing compelling that anything is imminent. But if I was going through a chronic illness, if things were not looking good and things were getting worse and worse, then probably I would like to know. Probably. Because I would want to sort my affairs. और इसकी एग्जांपल मैं आपको एक दूंगा. वन ऑफ द बेस्ट पेशेंट्स एक मेरे कोलीग के बड़े भाई थे, आई विल नॉट नेम द कोलीग ऑब्वियसली. उनको मैं देखता था. And he asked me very frankly how much time I have left, and I told him about 4 to 6 weeks. I would say I would be very surprised if you are alive after 6 weeks. So he said, "That's good. Thank you very much for letting me know." उसके दोनों बेटे बाहर पढ़ रहे थे इंग्लैंड में. उनका 2 कनाल का DHA में घर था. उसने घर खरीदा, बेचा, 10 मरले का एक घर लेके बेबेंग को लेके दिया, और बाकी दोनों बच्चों की जितनी, एक के 2 साल पेंडिंग थे, एक का 1 साल पेंडिंग था, उनकी फीस जमा कराई इंग्लैंड में, और अपनी बीवी के लिए सर्टिफिकेट लेके सारा करके. एंड देन 2 weeks later, when he came to my clinic, he showed me all of this कि मैंने सब कर दिया. So he had sorted all his affairs, and he was so much at peace when he came to my clinic. So yes, in that scenario, he wanted to know, and it was amazing कि उसने किस तरह अपने आप को plan किया. And I still meet the wife very अक्सर जगहों पे. She's a principal of a very famous school, so I run into her every now and then in various functions में. So that family really planned their things and got their affairs sorted. But ये चीज जो है ना, ये सवाल, I don't think इसका कोई जवाब है. The smallest coffins are always the heaviest. We cannot prepare for them. We can only make sure कि हम उनकी उस जर्नी को आसान कर दें. और मैं इसको एक एग्जांपल दूंगा जो बड़ी रफ सी एग्जांपल है, बट मैं अपने मरीजों को भी ये देता हूँ कि ट्रेन, जब सफर ट्रेन का करें आप, तो ट्रेन वेरियस प्लेटफॉर्म्स पे रुकती है. तो जब किसी प्लेटफॉर्म पे ट्रेन रुकती है तो चाय वाला भी होता है, अंडे वाला भी होता है, पानी वाला भी होता है, अखबार वाला भी होता है. तो हम हेल्थ केयर प्रोफेशनल उस प्लेटफॉर्म पे खड़े चाय वाले, अंडे वाले हैं, जो आपके सफर को आसान तो बना सकते हैं चाय अंडा देके. हम आपके साथ ट्रेन में बैठ के ये सफर नहीं कर सकते, बिकॉज वी आर नॉट गोइंग थ्रू दैट. ये कहना कि आई नो व्हाट यू आर फीलिंग, उस बच्ची ने मेरा मुंह बंद करा दिया था ये कह के कि आपकी 15 साल की उम्र में मां नहीं मरी थी. हाउ डू यू नो व्हाट आई एम फीलिंग? व्हाट आर यू टॉकिंग अबाउट? यू आर नॉट अ 15-year-old girl. So don't tell me कि you know what you're feeling. You know what I am feeling. You don't. So उसके बाद से मैंने एक्चुअली अब ये एग्जांपल देना शुरू कर दी कि मैं वो चाय वाला अंडे वाला हूं जो आपका सफर आसान कर सकता है आपको चाय अंडा पूछ के, लेकिन मैं आपके साथ इस सफर में नहीं जा सकता. ये आपका सफर है. आई एम सॉरी अबाउट दैट. So how common is the problem? We're all going to face this. Who looks after them? In an ideal world, I feel the loved ones should look after them. I do not think the healthcare providers, we are not the right people. Yes, if we need to give specialist input to manage symptoms, we should certainly be doing that. But beyond that, I don't think we are the right people to be dealing with them. क्योंकि हमारे लिए हमेशा वो एक केस ही होगा, कमरा नंबर 232 ही होगा. हमारे लिए कुछ भी हम कर लें, जितने मर्जी सेंसिटिव डॉक्टर बन जाएं, हमेशा वो यही होगा. हम उनसे डील करके नीचे जाके गप भी मार रहे होंगे, सियासत भी डिस्कस कर रहे होंगे, शाम को खाने पे या शादी पे भी जा रहे होंगे. सिम्टम्स कॉमन क्या है एंड व्हाट इज अ गुड डेथ? हमने सिम्टम्स पे मैं अभी आता हूं. ये सिर्फ मैं आपको डायग्राम दिखा रहा हूं, ट्रेजेक्ट्री क्या होती है. सडन डेथ यू कैन नॉट प्रिपेयर फॉर इट, इजंट इट? यू आर लिविंग अ नॉर्मल लाइफ, कार एक्सीडेंट हो गया, टेररिज्म हो गई, आप टर्मिनल इलनेस यू कैन प्रिपेयर फॉर इट. जहां से वो चीज नीचे जाना शुरू हुई है, वहां से आप समझ लें कि आपको पता है कि ये चीजें नीचे जा रही हैं, तो उस ट्रेजेक्ट्री में कहीं पे भी आप ये तैयारी शुरू कर सकते हैं. सिमी तरह ऑर्गन फेलियर्स, फ्रेल्टी, इसमें यू हैव वैक्सिंग एंड वेनिंग, बट यू आर गोइंग टुवर्ड्स अ डाउनवर्ड ट्रेजेक्ट्री एंड यू नीड टू बी प्रिपेयर्ड फॉर इट. सो I'm going to try and end my talk on the symptoms that we feel at the end of life. बहुत स्टडीज के बाद we are told that there are about 4-5 cardinal symptoms at end of life. The first one being pain. Pain के लिए management, we can discuss endless ways. You can do nerve blocks depending on the site of pain and the site of tumor. You can do but I generally do use the WHO analgesia ladder. I start with simple paracetamol, NSAIDs. I go on to weak opioids like codeine, tramadol, tapentadol, and then I go on to morphine, agar morphine available ho every now and then. Pakistan mein ye bhi ek role hai. The next thing is dyspnea. Again, try and establish the cause of dyspnea. I feel you can never be a good pediatric or adult palliative care physician if you're not a good physician first, because you need excellent communication and you need be an excellent diagnostician. Dyspnea doesn't necessarily always mean lung meds. It could be a treatable cause. It could be pleural effusion. Always try and see कि इसको ये symptom क्यों हो रहा है, और ये हर symptom के ऊपर हम आधा घंटा की talk अलग कर सकते हैं. ठीक है ना? So I'm not going to waste time here, but you're all doctors, you'll all agree with me कि अगर मैं एक dyspnea in a cancer patient कहूँ, तो you can think of at least 15 causes each of you कि उसको dyspnea, उसको embolism भी हो सकता है, उसको heart failure भी हो सकता है, उसको lung mets भी हो सकते हैं, उसको pneumonia भी हो सकता है. तो ये list is endless. Nausea and vomiting, again, and agitation. अब अगर इन चारों सिम्टम्स को मैं एंड ऑफ लाइफ पर्सपेक्टिव में ले लूं, और अगर मैं इस फ्रेम ऑफ माइंड में अब आ गया हूं कि ये चंद घंटे या चंद दिन की कहानी है, तो आई एम नॉट गोइंग टू गो थ्रू इन्वेस्टिगेशन ऑफ देम. आई एम गोइंग टू फोकस मोर ऑन अचीविंग कंफर्ट अराउंड देम. पेन के लिए ओपियोइड्स, डिस्निया के लिए भी ओपियोइड्स आर वेरी इफेक्टिव. नॉजिया एंड वॉमिटिंग के लिए मेरी फेवरेट दवाई हेलोपेरिडोल है. हाउ मेनी ऑफ यू आर अवेयर दैट इट कैन बी यूज्ड फॉर नॉजिया एंड वॉमिटिंग? Good. So opioid-induced nausea and vomiting, haloperidol is the drug of choice. ठीक है, खासतौर पे अगर आपका पेशेंट ओपियोइड पे है. इसके अलावा लीवो में प्रोमोजीन बहुत अच्छी है, वो भी पाकिस्तान में कुछ अरसा अवेलेबल थी, हमारे पास आती थी, आजकल फिर नहीं आ रही, लेकिन उसको मंगाने में कोई मसला नहीं है. मॉर्फिन को तो मंगाना एक बहुत बड़ा मसला है. इट्स अ वेरी गुड ड्रग बिकॉज इट ऑल्सो हैज सेडेटिंग इफेक्ट, सो इट्स वेरी गुड. एजिटेशन के लिए in our practice at Shaukat Khanum, we use midazolam most frequently, and that's one of the best ones that you can use. So in end of life, there is a cocktail that you make and you give it through a syringe driver. लोगों को IV का ज्यादा पता होता है, IV दवाइयां देने की जरूरत नहीं होती end of life में. You can give them subcutaneously through a syringe driver with just as much bioavailability and efficacy as an IV. IV line maintain करना is painful. It's in itself, हर रोज एक नया Venflon लगाएं, चीजें करें. A subcut needle is better, less painful. कभी पेट में, कभी टांग में लगा ली, and it's more effective for the patient as well. And you make a cocktail in this. And while we are on this, the father of all of this, Robert Twycross, recently died. I don't know how many of you have heard the name of Twycross, but तमाम ये syringe drivers, ये cocktails, ये उसने बनाई थी. उसकी किताब भी, Twycross is the Bible of which medication can be mixed with which one to use at end of life. It's a whole book on that. And the chap recently died. I had an email from Palliative Care Association. And then last is the death rattle, जो कि वो खड़ उनके मुंह में शुरू हो जाती है. Very distressing for the family, very distressing for the caregiver. Actually not very painful for the patient, but it's very distressing. इस तरह करके वो फूक होती है क्योंकि मुंह में, तो you can use glycopyrrolate, you can use hyoscine for that. दोनों चीजें अवेलेबल हैं. पाकिस्तान में palliative medicine, especially pediatric palliative medicine, या दुनिया भर में, it is a very emotionally challenging field. I at least do not still feel after all these years that I am ready. I dread it. I'm quite happy कि ये मुझे consult ना भेजें. I dread it जिस दिन मुझे consult आती है मेरे week में peds की, because मुझे वाकई अभी भी 16 साल ये करने के बावजूद, no jokes apart, I do not still know how to go and approach that patient without getting too emotionally involved or without getting too heavily emotional. And I respect pediatric oncology colleagues कि ये day in day out कैसे deal करते हैं इन बच्चों से, because मुझे तो हफ्ते 2 हफ्ते में 1-2 बच्चे देखने पड़ते हैं और मुझे तो बिल्कुल ही पसीने छूटते हैं literally, because it's very difficult. मुझे ये लगता है जैसे कुछ ज्यादती हो रही है यहाँ पे. ये बच्चा अभी स्कूल नहीं गया, इज नॉट हैड, इसने कोई बदमाशियां नहीं की, इसने कोई फड्डे नहीं किए, इसने कोई डेटे नहीं मारी, इसने जिंदगी नहीं एंजॉय की अभी, और ये क्या इधर लेटा हुआ है बच्चा 5 साल का. मुझे लगता है कि कोई ज्यादती हो रही है. आई स्टिल हैव टू टेक ऑल माई रिलीजियस थिंग्स टू ट्राई एंड कन्विंस माई सेल्फ के ठीक हो रहा है जो भी हो रहा है, कुछ ना कुछ समवन somewhere knows what's going on. There are so many gray areas. बच्चे के साथ how do you tell the patient's parents के जी हमने इसको नहीं खाना देना? The most adult में इतना challenging होता है, बच्चे के तो parents को आप कह के तो देखे इसको खाने के देने की जरूरत नहीं है. But आपको you have somebody has to do this. There's so many. Then comes the concept of euthanasia and physician associated suicide. हमारे मुल्क में ये बिल्कुल भी नहीं है, but जिन countries में है वहाँ पे ये है, and you need to be aware of these things. Then most legal issues आ जाते हैं. Family issues आ जाते हैं. I dealt with a 2-year-old, and I'm going to end my talk on this story. उसका नाम भी मुझे याद है. They were from a very high-flying family from Faisalabad, very famous family, and the boy was hardly 22, 23. The girl was 19. The parents, and छोटा सा उनका बच्चा था. The child was dying. And our repo was very bad from day one, in the sense कि जब मैं पहली दफा उनके पास गया तो उन्होंने, वो थोड़े से रिलीजियस लोग थे, तो उनके बच्चे के दादे ने कहा कि आप तो ये टाई वाई पहन के आ जाते हैं, तो आप तो बेहतर है कमरे के बाहर ही रहा करें, फरिश्ते ही नहीं आते कमरे में जो इस तरह मगरबी लिबास पहन के आता है. तो so this was my first encounter with them, but I used to sit with the parents. Then the typical thing happened कि जी ये जो लड़की है ना, इसकी फैमिली में कैंसर बहुत है, तो इसको तो तलाक दे दी जाए, ये बच्चा तो अब मर रहा है. तो दिस इज वेयर द सिचुएशन फैमिली डायनामिक वाज. सो आई यूज्ड टू काउंसिल दिस. लड़का जब वो मुझे अकेले हत्थे चढ़ जाता था, मैं उसको बड़ा काउंसिल करता था कि यार इतनी अच्छी लड़की है, गुड लुकिंग है, प्यारी बच्ची है, ये तो किसी के साथ भी हो सकता है, इस तरह मत करना इसके साथ, ये कभी ना करना खुदा के लिए, ये वो. I counseled them, बड़ा हुआ, the child died, everything, they went home, never heard from them. About 8 to 10 months later, मैं नमाज पढ़ रहा था मस्जिद में, तो किसी पेशेंट ने ऐसी मुझे हेलो किया, एंड थिंकिंग कि यार अब ये कोई शिकायत करेगा, मैं वहां करके उसको इग्नोर करके चलता हुआ गया. जब मैं चलता हुआ जा रहा तो मुझे स्ट्राइक किया, यार ये तो वही लड़का था, अब उसने दाढ़ी रख ली हुई थी, पहले वो मेरी तरह क्लीन शेव था. मैं जब दफ्तर पहुंचा तो मेरे दफ्तर के बाद वो खातून भी बैठी हुई थी, लड़की. तो देन दे बोथ केम इन एंड दे सेड कि जी हम आपका शुक्रिया अदा करने आए हैं क्योंकि आपने हमारी शादी बचाई, आपने हमें बड़ा काउंसिल किया. मैंने कहा कोई बात नहीं, मैंने कुछ नहीं किया, आपके अपने फैसले हैं, ये वो. But then they said to me, and it made my day that day, and still, if I'm upset at my work or job, I think of what that lady said. She said कि जी I'm expecting again, और हम डॉक्टर से सीधा आपके पास आ रहे हैं, ना मैंने अपने माँ बाप को बताया, ना इसने अपने माँ बाप को, क्योंकि हमारा कंबाइंड फैसला था कि हम सबसे पहले डॉक्टर हारून को बताएंगे. तो वी आर ड्राइविंग फ्रॉम फैसलाबाद जस्ट टू लेट यू नो in person before we go back home and tell everyone. And that made my day. This is, oh, there is hope. It's not all bad. It's very tough to do, but when you do it, you start getting into the flow. I wouldn't say you enjoy it, but you feel satisfied कि आपने उस स्टेज पे इनके साथ अच्छाई की है जिस स्टेज पे मोस्ट लाइकली उनकी अपनी किस्मत ने भी उनको छोड़ दिया. So बाकी ये चीजें I'm not going to do what, but I'm going to really talk about the way forward, which is this is a public health issue in my opinion. Pakistan में we need to, for God's sake, we need to improve access to palliative care. We need to improve access to medications. It is so frustrating. One of our palliative care physicians, आप में से कुछ पुराने लोग हैं यहाँ पे, मुझे शक्लें जो आ रही हैं वो याद होगा, ऐसे नजर एक होते थे मेरे साथ, एक और palliative care physician. When he resigned, मैंने उसे कहा यार क्यों जा रहा है छोड़ के ये वो, और इतना अच्छा भला है, हम दोनों इकट्ठे काम कर रहे हैं, ये वो। उसने कहा यार इस मुल्क में जीना तो मुश्किल है ही है, इस मुल्क में मरना भी मुश्किल है, हर दूसरे दिन मॉर्फिन बंद हो जाती है, आई कैन नॉट डील विद दिस फ्रस्ट्रेशन, आई एम लीविंग, एंड ही लेफ्ट फॉर, एंड ही इज डूइंग वेरी वेल इन टेक्सास, इन एमडी एंडरसन एंड एवरीथिंग। बट एक दफा हुआ ये कि मेरी एक हिस्ट्री है कि मैं 5-6 साल यहाँ काम करके 6-8 महीने के लिए शौकत खानम छोड़ के बाहर चला गया था, फिर वापस आया, तो मैं छुट्टी जा रहा था, तो किसी पेशेंट को जो मेरा पुराने जमाने का चल रहा था, ये लगा कि मैं वापस इंग्लैंड जा रहा हूँ, तो मेरे कमरे में आके उसने वो तकरीर की कि आप लोगों को शर्म आनी चाहिए, आपको क्या लगता है कि गोरों के बच्चों को ज्यादा जरूरत है, हमारे बच्चों को जरूरत नहीं है, हमारे लोगों को जरूरत नहीं है, आप कैसे बाहर जा रहे हैं? मैं कहा बीबी ये मेरे हाथ देखे, मैं सिर्फ छुट्टी पे 2 हफ्ते के लिए जा रहा हूँ, 2 हफ्ते बाद आऊंगा। फिर वो बड़ी शर्मिंदा हुई, सॉरी वॉरी करके चली गई। So number 2 problem in Pakistan is access to medications. WHO list of essential palliative medications उठाएं आप, तो उसमें से कई ऐसी दवाइयां जो हमारे मुल्क में है ही नहीं. And so sad in 2024. And the saddest part is कि दुनिया की 70% मॉर्फिन का कंपाउंड अफगानिस्तान में उड़ता है और उसका 90% पाकिस्तान से ट्रैफिक होता है लीगली एंड इलीगली। येट पाकिस्तान में मॉर्फिन मेडिसिनल यूज के लिए फ्रीली अवेलेबल नहीं है। आपका यूजेज इज 0.001 milligrams per capita. The usage in the US is about 6 milligrams per capita. That just tells you the difference where we are in Pakistan, unfortunately. Well, अब हमने पैलिएटिव मेडिसिन की तो फेलोशिप बना ही ली है, उसमें भी हमें 10 साल लगे, बैक एंड फोर्थ ये वो। आई थिंक द वे फॉरवर्ड इज कि पैलिएटिव मेडिसिन की फेलोशिप को डेवलप किया जाए और पीडियाट्रिक पैलिएटिव केयर को एज ए सेपरेट स्पेशलिटी किया जाए। वाई? स्पेशलिटी ट्रेनिंग बहुत अच्छी है, बड़ी अच्छी बात है, लेकिन ये स्लाइड जो है ना, इसको याद रखिए, दिस इज ऑल ऑफ अस, एवरीबडीज बिजनेस इज पैलिएटिव केयर, इट इज नॉट जस्ट वन पर्सन्स जॉब। हॉस्पिटलिस्ट का भी काम है, ऑन्कोलॉजिस्ट का भी काम है, पैल केयर वालों का भी काम है, सर्जन का भी काम है, फैमिली का भी काम है, फिजियोथेरेपिस्ट का भी काम है, साइकोलॉजिस्ट का भी काम है। लेट्स ऑल जॉइन हैंड्स एंड लेट्स मेक श्योर दैट वो जो बात है ना कि वी कैन ओनली ट्रीट सम थिंग्स, वी कैन ओनली क्योर वेरी फ्यू, बट वी कैन ऑलवेज केयर. So let's show that care and compassion in not only to our patients, but with one another as well. We need to realize with one another as well that sometimes some of us may be going through burnouts, through compassion fatigue. तो किसी एक चीज को, वाक्य को उसके ऊपर लेबल ना लगा दें आपस में। We all, सबसे पहले तो हम ही को एक दूसरे की सपोर्ट बनना है जो इन चीजों के साथ डील कर रहे हैं। So thank you very much on that.
Thank you very much, Dr. Harun, for the emotional and the inside talk. And I think ये है कि आप दुआ मांगे अल्लाह मियाँ से कि अल्लाह मियाँ आपको बेहतरीन मौत दे। जब आप नमाज पढ़ते हैं ना, so I've made a point since the last 1 or 2 years कि आप दुआ मांगे कि अल्लाह मियाँ आपको बेहतरीन मौत दे, ठीक है? So the next 15 minutes we will be having a small case to discuss. Dr. Shahid will do the presentation, and it's about a patient where we had challenges dealing with end of life care. So the panelists, Dr. Resham, Dr. Harun, and Dr. Shakila, who's online. So once he's done with the presentation, I would ask the audience and the panelists to discuss and tell us what is the way forward in dealing with such situations.
Assalamu I'm Dr. Mohammed Shahid. I'm fellow in pediatric oncology, and I'm going to present a case about end-of-life care. We had a 6-year-old girl with relapsed right-sided Wilms tumor. She was presented to us in the emergency department with worsening abdominal distension, vomiting, and constipation for 1 week. Previous history: at 2 years of age, she was diagnosed as non-metastatic right-sided Wilms tumor. Right-sided nephrectomy was done on 7th of May 2020 after giving pre-op chemotherapy. She was treated with 27 weeks of post-op chemotherapy with flank radiotherapy. And first-line treatment was completed at 16th of November 2020. Unfortunately, she relapsed in November 2023, almost 3 years after end of treatment. And CT abdomen was done at that time, and that showed a recurrent large heterogeneously enhancing mass at the right renal bed. displacing and causing compressive effects on surrounding viscera and vessels. Stomach was also distended and intrahepatic biliary dilatation was seen, likely due to mass effect by the mass. And this mass was also compressing the vena cava. Relapse was confirmed on the biopsy and she was started on chemotherapy, but due to disease progression only after 2 cycles, we were not able to proceed further chemotherapy. And the case was discussed in MDT, and the MDT decided that as mass was not surgically resectable and palliative radiotherapy was also not possible due to extensive disease. So it was a decision by MDT that she was shifted to multidisciplinary palliative care on 12th of February 2024. We have the further we will discuss about adequate pain control for that child, nutritional support, and psychological and emotional support to the family. We had challenges to deal this patient. I would like to invite panelists to discuss about this case.
So can I ask, what did you use for pain medications?
वो नजर नहीं आएगा और माइक सिर्फ यही चल रहा है for the online. That time she was only on paracetamol when she was referred.
Okay.
So, when she was referred to Palcare, she was only on paracetamol at that time and PR and tramadol.
Okay.
Anybody from the audience? Anybody who want to talk about pain control? Ji, Adil. If you don't mind, could you walk here and talk on this one because our online person cannot hear the other mic.
Action. So one thing which comes to my mind, and can you hear Dr. Shakila?
Yes, I can.
Wonderful.
Thank you.
Adil, pediatric hospitalist at SKM. One thing which comes to my mind when I hear cases like that, and Harun, you also mentioned that ye bas dua karoge Dr. Harun ke paas na jana pade. Many times I think what palliative care gets involved at a later end, even in a lot of oncology cases. Does this bring up argument for actually involving palliative care earlier in the journey of such sick children?
Yes.
So yeah, I mean, if you look at the newer models of palliative care, agar aap wo, mere paas is waqt slide nahi hai, but yesterday in the palcare session, one of the speakers showed that the older model was that you had diagnosis and then you had curative treatment with the oncology team or your specialist team, and then you were referred to the palliative team, and then you had that. So it was a straight line. Now they actually make a tangent like this. So the input from the curative team is maximal. The input from palliative team is very minimal. But as the disease advances, the input from the curative team keeps going down and the input from the palliative team keeps going up. And this is the ideal way of delivering palliative care so that there's a smooth transition. The family never feels abandoned. And actually, they know both the teams equally good because they've been dealing with both the teams alongside. And there is no reason why the palliative team cannot be involved from the start of the treatment because many patients suffer symptoms due to their treatment like radiotherapy, like chemotherapy, or the treatment will take some time to work. And during that time, being referred to a PAL care means that their symptom control will be better, where studies have shown that that will mean their compliance with aggressive curative cancer treatment will be better because your symptom control will be better. Telling somebody कि radiotherapy अभी 4 हफ्ते होएगी, फिर उसके 6 हफ्ते बाद सही दर्द का control आएगा. Nobody's going to wait 10 weeks for pain. So you should be doing this alongside.
I agree with you, but I have a comment about that because I started the pediatric palliative care program at Mayo. And we started calling it palliative care, and I realized that we got a lot of resistance trying to get involved earlier. So we had a very good chaplain who suggested that we change the name, and our team is now called Compass. It's comprehensive care of and symptom control of pediatric and adolescent patients. And I have to tell you, it is one of the busiest. I started this program in 2006. And we started with 2 physicians who were volunteers. We didn't get time. We were doing it as extra on top of what we were doing. But now it's one of the busiest consulting service. We have 5 physicians, 2 nurse practitioners, 1 social worker, 1 nurse. So the Compass name opened up the window of everything. And only 25% of our patients were oncology patients. You won't believe it. The rest were all these other neurological disorders, cerebral palsy, all these other patients. So I think the name also has an effect, but I totally agree. We should start at the beginning. And my first love is stem cell transplant. And since I was doing palliative care, we tried to get the team involved when our patient came for transplant. So totally agree with you. It should be started earlier.
Yeah, Resham here. I totally agree with you, Dr. Shakila, and of course with Dr. Haroon. But sometimes we also think, yes, name has a role to play as well. But how I do in Karachi is like, although I have kept a name of quality of life team over there, but when I introduce myself, I always say that मेरा नाम Dr. Resham है. और मैं भी आप जैसे अगर किसी ऑन्कोलॉजिस्ट ने बुलाया सो मैं भी एक ऑन्कोलॉजिस्ट हूँ बट मेरे पास एक स्पेशलाइज्ड ट्रेनिंग है जिसका नाम पीडियाट्रिक पैलिएटिव केयर है यानी आमना और आमना जैसे वो बच्चे जिनके इलाज तक का सफर लंबा और मुश्किल है ना सिर्फ आमना के लिए बल्कि उनके पेरेंट्स और उनकी ख्याल करने वाली टीम के लिए उसमें उनका ख्याल और उनके रोज के दिन को बेहतर कैसे बनाना है. That's how I introduce myself. But do try to take a name of pediatric palliative care as well. But keeping as quality of life.
I'm telling you, in America, even now, the palliative care has this stigma. So I'm just trying to tell you that this was a stigma. Now, I mean, we started this service in 2006. So it's been there for a long time. But that I realized that even here that there is a stigma with the palliative, calling it palliative care. So we decided to change our name, and a lot of places here in America, they don't call the pediatric program, especially have these different names because of this. So.
And we do see patients as a pre-BMT evaluation thing as a pediatric palliative care. So I do go and meet with the families as an evaluation thing and finding out whether they need more so that converts into a comprehensive new consult for them.
Exactly.
While we're on nomenclature, actually, there's new literature out, which I want to bring to Shaukat Khanum now. DNR, just do not resuscitate, is always a stigma. They've started, some trusts in the UK have started calling it A&D, allow natural death.
Yes, we call it that
makes all
too.
the difference.
Yes.
So we still call it DNR in Shaukat Khanum, but I've started making a case and preparing a proposal for the leadership to start calling it A&D, which is allowing natural death. बात वही कर रहे हैं लेकिन वो semantics से बहुत फर्क पड़ जाता है.
Right, exactly. We call it A&D too. Right, exactly. I totally agree.
Can I just add to what Dr. Adil's point about integration of palliative care? So the literature and the evidence that is being practiced in the West is for oncological patients, palliative care should be integrated within 6 to 8 weeks of diagnosis of cancer. So that is how early it is started and not like how it's being practiced in Pakistan at the moment.
Sorry. So, sir, there is another thing like primary palliative care and then complex care. So in our settings where we don't have trained pediatric palliative care physician and maybe the turn and the burden of patients is so high. So maybe all of us need to develop those skills to some extent to provide that primary care at least. So that's how we can integrate from the beginning.
That's why my last slide was palliative care is every business. It's not just two people's business.
And I think we as pediatric oncologists, we are providing that primary palliative care in terms of we are managing basic symptoms. We are discussing with the families, goals of care plans. We are caring for them. But we do not even, sometimes we do not recognize that this is what we are doing as a primary physician for them. Because we need to
Right.
just learn more about the skills and all that we all are learning, because something new in our part of the world. So yes, we're already doing it, but we need to just, you know.
So I would like to add some points. So yeah, as we discussed that palliative care is not a business of only one or two person. It should be a teamwork. So I would
Right.
like to highlight importance of nursing care, that when we are establishing pediatric palliative care, then the nursing has very, very important role, because they spend more time with the patient and their family, and with the good trained nurses, they could provide a very good care to patient and their parents and other family members. So coming back to the case which we discussed, so I would like to highlight, so as we discussed that the one challenge was pain care. When we involved palliative care, then it gradually got better, and initially child was unable to sleep. And when I was meeting parents, parents were saying that she is in a lot of pain, she's unable to sleep, but gradually with escalation of pain medicine, it got better. And then parents were very relaxed that now she's able to take some rest, she's is able to have some rest and sleep, good sleep. And then the later challenge came was feeding. And as the Dr. Harun also mentioned, it's very hard to let parents know that you can't give any food. And especially when we make patient NPO, that's also very hard for me, because that's very challenging for parents to stop even a patient on curative treatment. So again, it's very difficult when the parents want that at the end of life care, they should provide the food which the child like and want to eat. So we had faced a big challenge in this child because of the huge mass. It was causing severe compression on stomach and duodenum. Initially, she was having a lot of vomiting, aspirate through NG, but then it got a bit better. And we tried every means with involvement of palliative care, what we can give, we can do to give food to her, but every attempt was not successful because she was not able to have NG feed. We tried to have nasovaginal feed, that also failed. We tried to give TPN, but when she was not DNR, when we were still giving curative chemotherapy, but she was also having high bilirubin. So in the end, when she family was ready for discharge, and then parents said that she's asking for food, and we just feel helpless that we even can't give any single small thing to give to eat her, to her. And it was causing a big psychological and emotional impact on family members. And again, same challenge which Dr. Harun mentioned, morphine availability. So until she was in hospital, pain got better on subcutaneous morphine. But when she and the parents also want that she should die at home. But at home, we didn't have measures, like we don't have morphine suspension, which we can give to children. Obviously, we don't have such home care that the syringe drivers through subcutaneous infusion morphine can be given at home. So these were the challenges in this case.
So we'll address feeding first. And in the interest of time, I'll just go over what we've started doing as a practice. Generally, हमारे culture में खाने की बहुत अहमियत है, और मेरी तो अपनी जिंदगी में खाने की बहुत अहमियत है. So therefore, I don't really stop any patient from eating anything. But जहाँ पे मुझे ये लगता है कि उसका diet लेना is going to be detrimental because of the risk of aspiration and things like that, then it's easier to explain to the family. The mass is compressing the stomach. So obviously it's easier to explain to the family कि खाना देना is going to be more नुकसानदेह than नहीं देना. And इसका एक और तोड़, which is again a practice thing that I visited once in another hospice and I saw it and I started with my patients, is कि अगर वो खाना निगल नहीं सकते, और if you know जिनको आप पैक से दे रहे होते हैं खाना, उनको अक्सर ये होता है कि मैं मुंह से खाने का मजा नहीं आ रहा. तो ऐसे भी पेशेंट्स, और जो खाना खा भी नहीं सकते लेकिन वो मुंह में इतने होश में होते हैं कि टेस्ट ले सकते हैं खाने का, I tell them to actually eat whatever they want, chew it, taste it. 20% of your nutrients get absorbed from your mouth, and then just spit it out. Don't swallow it. And you will be amazed at the wonders it causes in terms of satisfaction, because वो आपने एक negotiation करके agree कर लिया कि अच्छा निगलो नहीं, चलो खा लो. तो नहीं लगता कि खा तो मैंने फिर भी लिए, पूरी रोटी मैंने चबाई, सब कुछ. And it's a fact that 20% of your nutrients are absorbed from the mouth, and carbohydrates are digested. This process starts in the mouth. So it still gives some relief to patients.
One thing just to add on to what Dr. Harun said, I think for our anxiety as a care provider, just like you mentioned, so when we think about what were the goals of care plans for that patient, we were here to provide comfort. So जब आप हम ये सोचते हैं खुद से कि the goal is to keep her comfortable, so what are the things that can keep her comfortable? Is it less feeding, more nutrition, less fluid, more fluid? So जब हमें ये अंदाजा होगा कि क्या चीजें, that's how you speak with the family, that हमारा shared goal was to keep her comfortable. हमें लगता है कि अगर वो बिल्कुल चाहती है खाने के लिए, लेकिन हम ट्राई कर सकते हैं, अगर वो एब्जॉर्ब कर सकती है, ले सकती है, निकाले, लेकिन हमें लगता है कि उसके लेने से उसकी तकलीफ में इजाफा होगा, कमी नहीं होगी। लेकिन हम पूरी कोशिश कर सकते हैं कि जो हम आपकी ख्वाहिश को पूरा करें। इट्स ऑल अबाउट थिंकिंग कि हमने क्या गोल्स किए थे एंड डिस्कसिंग विद द फैमिली, ताकि हमें भी तो इत्मीनान हो जब हम उस कमरे से बाहर निकलें कि हमने जो किया है वो सही किया है कि नहीं किया, वरना हम उस डिस्टर्ब माइंड के साथ न जाएं, अगले पेशेंट को फिर हम देख भी नहीं सकेंगे। आई थिंक ये चीज।
Okay, so there is a question from the chat. Can paracetamol be used for cancer pain?
Yes,
the
of
beginning.
course it can be. It's
Yes.
the step one of WHO analgesia letter.
Right. That's what I'm going to talk about. Absolutely.
आप कुछ कह रही हैं?
Keh rahi hai, it's a
No,
very
no.
good drug. Dr. Shakila, आपने कुछ कहा है?
Yeah, मेरी talk इसी पे है.
I know.
So I can talk about that.
Do we have any more questions? Yes.
Assalamu alaikum. I'm Dr. Irsa from Children's Hospital. I have a technical question on pain control. I have observed in my personal practice, like treating the patients, that different type of patients from different regions of Pakistan, they respond very differently to the same doses of same drugs. So is there actually a difference of, maybe culture or region or genetics that is involved? Like same patients from Khyber Pakhtunkhwa, they don't really respond to our drugs very well, the way patients from Punjab does. So is there actually a difference, or it's just something?
I'm only happy कि हमारे केपी के colleagues बहुत कम हैं यहाँ पे। ये हम लोगों एक हमारे ज़हन में है ये बात। But opioids have a varied bioavailability genetically.
Right.
So I may require, for the same amount of pain, I may require 15 milligrams of opioids, of a certain opioid, जिसको आदिल को सिर्फ 5 milligrams चाहिए. And that's not because कि मैं कोई आदि नशई हूँ या कुछ हूँ. It's because मेरी बॉडी जो है वो 15 मिलीग्राम्स में से एक्टिव मेटाबोलाइट सिर्फ उतना ही निकाल पाती है, वेयरएज आदिल की बॉडी उतना मेटाबोलाइट 5 मिलीग्राम में से निकाल देती है. सो जब हम ओपियोइड्स की बात करते हैं ना, फॉरगेट पैरासिटामोल, एनासिड्स, वो ठीक है, एक तो पेन थ्रेशोल्ड इज समथिंग जो हर एक का डिफरेंट होता है, इसमें तो कोई शक नहीं. बट ये एक फैक्ट है कि फॉर द सेम टाइप ऑफ पेन somebody may need much higher doses because the enzymes that convert the opioids into active metabolites are much slower in their body.
And especially, sir, in case of tramadol, I would add, because tramadol is a drug which is still not widely recommended for pediatrics all over the world. Although we are using extended in Pakistan, so that comes true for tramadol specifically.
पाकिस्तान में ये भी चैलेंज आ जाता है ना कि you are very limited in what you have.
Yeah.
So you
We don't use
the best we have.
things like
We don't have
tramadol.
oxycodone, we don't have hydromorphone, we don't have short acting morphine.
Exactly.
तो आप 2 साल के बच्चे को 10 मिलीग्राम लॉन्ग एक्टिंग मॉर्फिन तो नहीं देना चाह रहे होंगे. So therefore you are stuck.
We didn't get to see many side effects with tramadol, amazingly.
Yeah.
हमारा
But
experience
as long as you avoid them in patients with brain disease or epilepsy, that's
Neurological
the most
impairment.
important thing.
There is a concept of total pain. So it's not just physical pain, there's psychological
Yes.
component there. We try
Yeah.
to hit the pain with the medication that we do it for physical pain. But we don't think about the psychological pain. And sometimes every patient has their different pain goal and score.
Right.
अगर
And there's
आपने 1
spiritual
करना है
pain.
and 0 करना है तो आप उसको सुला दें, उसका pain 0 हो जाएगा. But maybe he remains functional at the score of 4. But we need to find out what is the goal or what is the number where you can do your work or proper, like आप functional किस पे रह सकते हैं जिसपे you don't need a medication. And above that Dr. Harun said, use the WHO letter कि 4 to 6 के pain पे I use paracetamol, 6 to 8 में I use tramadol और 8 से above जाएगा I use more. तो आप अपनी मॉर्फिन को भी कंटेन करके रखेंगे कि आप ओवर भी नहीं जाएंगे, आपके पास वैसी लिमिटेड स्टॉक है. बट थिंक अबाउट पेन एज अ टोटल पेन कॉन्सेप्ट, क्योंकि हम वही करते हैं ट्रीट जो हमें नजर आता हो. तो इट नीड्स प्रॉपर इवैल्यूएशन.
We call it spiritual pain. There is something called spiritual pain, which I have seen. Sometimes kids wait for their parents to give permission to go. And I don't know if you observe that in Pakistan, but I've observed that here, that sometimes they just need permission.
So we had one last question. So this was posted during Dr. Reshan's talk by Mariam Ibrahim. She said, what do patients want? You said hope, and how do you balance breaking bad news with hope? So maybe just a few comments on that.
So, thank you for the question. I think that's very important and pertinent question. I think hope is very different for different families and children and patients. So our job is to give them hope, but to not take hope from them. So we have to be very realistic in telling them that what's happening, but we need to tell them that what we can do better to make that time better for them. It doesn't
Right.
mean कि आपने कुछ भी नहीं करना तो ये कहना है कि कुछ भी नहीं हो सकता है, that you cannot directly take that hope from them. But उस scenario में आप क्या चीज best कर सकते हैं that can still give them hope to like move forward and with the time they have, whatever time they have. So I think if I was able to respond to your question well, and हमने वो psychological support और emotional support वो छोड़ दिया challenge.
Time खत्म हो गए.
Somebody has asked that a lot of universities in Pakistan have started offering 6 months diploma courses. As of today, the only recognized qualification in Pakistan for palliative medicine is FCPS palliative medicine, or boards, American boards, or a CCT from the UK. Those are the current recognized. So yes, these diploma courses, if you are an oncologist or a general physician or a family physician with an interest in palliative care, they'll help your practice. But you can't be an accredited specialist in palliative medicine currently in Pakistan with these. So this is just to clarify.
Thank you so much for the very interesting discussion. Moving on to our next talk, we'll request Dr. Shakila Khan. She doesn't need any introduction. She's a board-certified pediatric hematologist oncologist with special expertise in stem cell transplantation and palliative care. Dr. Khan worked in Mayo Clinic since 2002, and during her service, she directed a very successful pediatric BMT program over there and then expanded it to the transplant with unrelated donors and cord blood transplants. She just mentioned she started a pediatric palliative care program over there as well. She got retired in 2023 from Mayo Clinic, and now she's enjoying the status of Emeritus Professor of Pediatrics. So we are really looking forward to have a very interesting talk about the pain management by Dr. Shakila Khan. Thank you so much, ma'am, for joining us.
Yeah.
I think it's late hours over there, but
Yeah, it is, but it's okay.
thank you so much.
It's nearly midnight here. So anyway, I'm very happy that at least I could join. I couldn't come in person. So I've always had good times whenever I've been to Shaukat Khanum. So I will try to share my slides now and we'll go from there. Can you see them? Can you see my slides?
Thank you, Alina. Not yet. Not
No?
as yet.
Okay. Because I just did the sharing, so hopefully. Let me end it then. Let me
You
try
have
one
the
more.
options to share, Dr. Shakila?
Yes, I did that. So that's why I'm wondering why it's not doing it. Could
Okay.
you,
Can you
I
unshare
sent you
and
my
then share
slides.
again?
Let me try it. And show. Okay. So I'm bringing it up. Shaukat Khanum talk. Share. It says it's failing to start. I don't know why. So, okay. Usually it's very simple. You guys, I did send you the slides, so maybe we can just try that.
Dr. Shakila, we can see that happening, that you're sharing the screen. I think we can see that.
हम आपका Zoom देख रहे हैं.
No, but I tried to share my slides and it, okay, let me try one more time.
आप अपनी पूरी screen share करें, Dr. Shakila. हाँ, screen share कर लें.
Okay, so no, but I tried to share my slides and it's not letting me
No,
do
don't
that.
do
so-
that. Don't try to share your slides. Share your screen. So unshare and then try to share your screen and then
Okay.
navigate your slides.
Okay, so I'll stop share. Okay. It's very easy usually. I just put the share and my slides come up. So you can't, that's a pity.
So when you share, I share the screen. Don't share the slides. Just share the full screen.
Share the full screen. Screen. It is there,
Are you using two monitors or just one?
just one. Share sound. This has changed because usually,
Okay, we are starting to see something. Can you navigate to your slides now?
let me do my slides and see what happens. Okay. Let's see. Can you see the slides?
So now we can see your screen where the Zoom window is showing. Now we need you to minimize this and go to your slides.
Okay, can you see it now?
No.
It says my screen sharing is paused. Why does it say that? Because I can, it's interesting that,
Did you share the whole screen or just your slides?
no, I shared the whole screen first. See, so you can see me, right?
We can see you.
Right, so that's when I did the share.
Okay, so
And now can you see it?
hold on. We can, okay,
Oh,
yes,
yeah.
we can see this. Just put it on slideshow.
Yep, that's what I was trying to do and it's not letting me do that, so.
That's okay. We can, either you can zoom at the bottom. So at the bottom of the screen on the bottom right corner, yeah, just zoom
Mhm.
up, zoom a little bit more. And then I think we should be okay. We should be able to start seeing it. Yeah, so just go ahead. We can start, we can see something. We can see the slides. They're just not full
Okay,
screen.
can you see them better?
Yes. Yep. Yes,
Okay,
excellent.
good.
Go ahead.
So finally, okay, so let me go back first. So I'm going to talk about pediatric pain and palliative care. And the reason I became interested in palliative care is because of my transplant background. Because we do really well in transplant, but when the patients used to die, they used to die terrible deaths. And I always felt that we could do this better. So that's where my interest came in palliative care. And of course, it includes the comprehensive management of physical, psychological, social, and spiritual needs. And this is one of my favorite slides. So when I started the program, I created the team, and one of our chaplains, Warren Anderson, was with me. And when we presented it to the pediatric people about our plan, this is his slide, which I took. He says, our calling is our problem. Because always if you tell people that what you do, they always say, how can you do this? How can you work with sick and dying children? And Warren said, how can we not work with them? And I thought that was so appropriate. So children do die, as we all talked about. But I think it's us we are uncomfortable, and because we feel inadequate, because we are trained to save lives. So when things don't go right, we feel inadequate. And I think that's also has to do with how we communicate with our patients. What is palliative, appropriate? Was started that palliative care, we say, as for conditions that are likely incurable, progressive, and fatal, and for which quality of life, it's management of symptoms. And and there is a committee of bioethics in palliative care. When we started this, that, palliative care programs need to be available. And as we talked about, and Dr. Harun said, begin care at time of diagnosis. Continue no matter the outcome. That's what it is. And that's why it should be started from the beginning. And all who care for children need to become familiar and comfortable. And there is no rule for euthanasia. And I will talk about this later too, because I think it is a different concept. And the decision to forego life-sustaining medical treatment does not imply an intent to hasten the child's or choice to hasten the death of a child. So, and what is the pediatric pain and palliative care team? Somebody mentioned nurses. Yes, it's physicians, nurses, social workers, child life, chaplain, and psychologist. So we have this whole team which works together to make the patient comfortable. And our goals are multidisciplinary collaboration, provide organized care, relieve pain and suffering, enhance quality of life. I think that is very important. And of course, to train the staff and education. That's part of what we do too. So, and there are a lot of barriers to pain management, especially in pediatrics. There are professional barriers of inadequate knowledge about pain mechanisms, pain assessment, pain medications. This is very important. Fear of producing iatrogenic addiction. Even in transplant, when I use a PCA, when they have severe mucositis, some parents ask us, do you think they'll become addicted to it? And I have to reassure them that I've never seen a child get addicted to this because, they're in pain. You have to take care of their pain. Even in America, there is a fear of regulatory scrutiny. Actually, they have ways of looking at what physicians are prescribing and doing all this. So there is a concern about that, concern about side effects, and time and reimbursement pressures that prohibit effective pain assessment and management. What are the patient barriers? Sometimes patients are reluctant to report pain. They are reluctant to take pain medications as prescribed because of concerns about addiction, belief that pain is inevitable and not treatable, inability to manage side effects of medications, fear of masking new symptoms, and of course, cost of pain medications, because they are expensive. I like morphine. That's one of the cheapest drugs, and it's very effective. There are system barriers. And I think that's what you're facing in Pakistan. We faced it here too. Failure to make pain management a high priority. Absence of accountability for pain management. Lack of organized pain management teams and regulations which restrict the prescription and dispensing of controlled substances. And actually now it's getting better when the patient comes to come to our clinic. Our desk people, there is an assessment which they do with vital signs and all, and pain is included in that now. So we are also getting better. So this was a very good study by Joanne Wolf. She's at Harvard and she started the palliative care program there. And she did a survey of parents on end-of-life care when their children's passed away. And 20% of parents disagreed that their children were comfortable in their final days. 55% of parents felt that they had little or no control during their child's final days. And 25% said that if they were able, they would have made decisions differently. But what was interesting was that there was a significant discordance between reports of parents and physicians regarding the children's symptoms, with some suggestive evidence that this may result in part from a lack of recognition of the problem by the medical team. And bereaved parents who reported that the physician was not actively involved in care at the end of life were more likely to report that their child suffered a great deal from pain. And clinicians previously unknown to the family were quickly drawn into the family's inner circle of support because of their expertise. That is when the palliative team was called, and that was at the end. So they didn't know them well. So that is why it's important when we keep on talking about, getting them come in earlier. A little about pain. You all know this, but I thought it'll just good to go. It's an unpleasant sensory and emotional experience associated with actual or potential tissue damage. But important thing is pain is subjective. Whatever the experiencing person says it is existing, and whenever patient says it does. So you have to believe the patient when they say they are in pain. You can't say that, that happens even in America. Sometimes they think that, it's more than what it should be. So clinicians must acknowledge both physical and non-physical factors which may contribute to pain. And children may have emotional responses to pain, including anxiety, fear, anger, and sadness. And I won't belabor this, but the classic, it's based on pathophysiology, that there is neuropathic pain, nociceptive pain, which could be somatic, visceral. Neuropathic can be peripheral, central, can be acute, chronic. And so that you have to treat differently. And the different pain types, the nociceptive is following injury or tissue damage. And it's usually well-defined and localized. Visceral pain is from internal organs. This is less well-defined, poorly localized. And neuropathic pain is abnormal processing of nerve impulses caused by a lesion or dysfunction within the nervous system, which could be central or peripheral. A lot of our chemotherapy causes a neuropathic pain. So, we use a lot of medications for that. So acute versus chronic pain is that, acute is an identified event, resolves within days to weeks, usually nociceptive. Chronic, cause not often easily identifiable, multifactorial, indeterminate duration, nociceptive or neuropathic, and there can be pain-free intervals. And there can be chronic persistent pain, which is always there. So our patients can have any of these. So how do you evaluate pain in a child? So we have this QUEST acronym. I'm sure you all know about it. QUEST, you have to recognize pain is subjective. We do try to use some rating tools. You evaluate behavior, you sensitize parents and staff, and then you take action and evaluate results. And this is just another acronym, the PQRST model. What it provokes, what causes the pain? What is the aggravating or alleviating factors? What is the quality? It's sharp, dull, stabbing. Where does it radiate? How severe it is? Onset and duration, and when did the pain start and how long does it last? So we have different scales for assessment in PEDS. I'm sure you guys are familiar with it, but you can use whatever you are comfortable with. Because I usually use a numeric scale for older kids and adolescent, you have this body area, they can sometimes color and let you know, do a drawing and explain the pain to you. But this is Warren Baker-Facey's scale, which I think is mostly used where, you can see the child can point towards the face and tell you how much they hurt. This is the Oucher pain scale. If you see, the 10 is when they are really crying excessively, and 0 is when they're pretty quiet. So again, the scale is between 1 to 10. Same here, you can ask them, there's no distress to agonizing pain. So usually sometimes when older kids, I just ask them, okay, how would you rate your pain? If I say 0 is no pain and 10 is really bad pain, and they can actually tell you pretty well. So, and this is another one, which is called the flag behavior scale, and you add the points. And of course, minimum is 0, maximum is 10. Higher score indicates more severe pain. So we do pharmacotherapy, right? Medications should be used, but very important with age-appropriate non-pharmacological therapies. We do that a lot in pediatrics, which can help reduce the perception of pain and decrease the dosage requirements. And what are these non-pharmacological therapies? Massage therapy, acupuncture, healing touch, art and music therapy, biofeedback, distraction, guided imagery, relaxation, and hypnosis. I actually did training for medical hypnosis, and it was very interesting. And it does help. It's basically just training to work with the child about how and try to help them deal with the pain. Of course, you can apply heat and cold application. You can use humor, clown therapy. Older kids can do journaling. For newborn, in the NICU, they do kangaroo care, swaddling, positioning, oral motor stimulations, pacifier, physical or occupational therapy, storytelling, therapeutic play. That's where child life folks are a big help in trying to work with the kids with all these other therapies. We have pet therapy there. We don't have that in Pakistan, but here dogs are very, we have regular therapy dogs visit and kids love them. Aromatherapy, it actually helps with a lot of symptoms. And we actually, Mayo is very interesting. You have to get approval for everything. So when we applied for aromatherapy, we were allowed 4 scents. One was lavender, one was lemon citrus, and ginger, and there was another one. I think it was aniseed. So you can, there's something called quizzes where you combine the two. So what our nurses used to do was, especially with chemotherapy side effects of nausea and all, they would use cotton balls. We would have these oils and they would make these little balls and put them in plastic bags. And it worked for some kids. You have to give them a choice. Then there is something called progressive muscle relaxation, which is again, you can go, it's like, relaxation technique. You can go with the kids. Transcutaneous electrical stimulation, which is called TENS. Now it's available, but, physical therapists do that. So let's go to pharmacotherapy. Pain management should be based on the patient's age level. I usually don't do PRN meds. You give them around the clock, especially for chronic pain, given by the least invasive route. And there are many, tailored to the individual child's circumstances and needs. That's what basically it's all about. So you should do, of course, know your child, the history, physical presence of liver or renal dysfunction, because you have to adjust doses, disease progression, associate symptoms, nausea, anorexia, etc. Sources of pain, medication allergies, current medications for potential drug interactions, history of drug misuse in patient or family. This is important. I had a family in which we found out that we were prescribing the drug to the patient when they were at home, and one of the family members was using it. So you have to make sure that you are aware of that. And of course, ease and appropriateness of schedule is important. This is what Dr. Harun was talking about. I also follow that. This is the, cancer pain relief and palliative care in children. You do it by the ladder, by the clock, by the mouth, by the child. So just to give you an example, step 1, non-opioid analgesics, which actually I use both what you call paracetamol, we say Tylenol, and NSAIDs. If you can, if there's not major renal dysfunction, and you can alternate so that the kid gets something every 3 to 4 hours. So we do that. We use some oral, for mild, moderate pain, we use some weak opioids, oral morphine, there's, oxycodone, and then parenteral potent opioids if for moderate to severe pain. And of course, intractable pain, you have to use invasive therapy. And I'll talk about that. I have a patient who really challenged me, and I learned a lot about how to manage pain at end of life from him. So factors to consider is you schedule non-opioid medications. As I said, you alternate or schedule them. You can use paracetamol, give it every 6 hours. Use the non-pharmacologic strategies we talked about, symptom management. If they have nausea and vomiting, use Zofran. Dr. Harun mentioned Haldol, whatever works. Important thing is constantly reassess, and communication is the key. Medication route consideration, of course, oral is the best and feeding tube, but sublingual. We actually have Roxanol, which is a sublingual morphine. I really use that a lot in my end-of-life patients. You can have transdermal, subcutaneous, IV, intramuscular. You can do it many ways. You have the rectal route in pediatrics, patient-controlled analgesia, and epidural. And we do have we have a good pain team at Mayo, where the anesthetists help us do the epidurals if we need that. What about the dose we use? So when you start opioids, you start at the lowest dose and titrate it upwards judiciously. If pain is constant, round-the-clock dosing is preferred. And breakthrough pain should be treated with 10 to 15% up to the 1/6 of the daily maintenance dose. So when you are doing pain management end of life, your goal is to make sure that the patient is not suffering. So I think of that as the main goal for me. For unrelieved pain or receiving 3 to 4 breakthrough doses per day, the maintenance should be increased by 25 to 50%, and you should assess on a regular basis. And if you want to convert one opioid to the other, you have to consider the equianalgesic dosing. Just opioid choice based on organ failures, because sometimes our patients have that. Preferred is hydromorphone, morphine. We use methadone a lot too, oxycodone, fentanyl. And we have this luxury. I actually don't use tramadol, but I know that you are limited, so that's why you have to use whatever works. But we use, I really still am a morphine fan. I think it's a great drug to use. And we use fentanyl patches. So we have a lot of medications available. We have that advantage here. So I feel for you in Pakistan, because I always thought that how can you get these medications for people there with all the restrictions and everything? So for mild pain, of course, you start with paracetamol or ibuprofen, but I don't use PRN medications. That does not help with acute pain. But always remember comfort measures, because what the comfort measures does is it takes the patient, helps the patient not focus totally on their pain, and that can help them. And you could alternate meds if no pain relief. So patient receives the pain medication every 4 hours. I use that pretty usually. For moderate pain, you can still use scheduled non-steroidal, but you can start opioids in low dosage and then titrate to achieve better control. You could still use the oral route if patient is able to take meds. Severe pain, again, continue the non-steroidals, titrate opioids, dose and frequency. And again, you can use transdermal, sublingual, and PCA with continuous infusion with boluses for rescue. It is if the patient is, can do that. But sometimes we ask the parents to push the button, which is fine. But I think this is the most important thing. The treatment of pain at the end of life is the right of the patient and a moral duty, as well as legal obligation of the clinician caring for the suffering. And our goal is to keep the patient comfortable. So I will tell you balancing pain control and alertness so the patient can interact with loved ones. But this is what I'll tell you about. Palliative sedation for intractable pain can be used as a last option. So I had a patient. He was 9 years old who failed 2 transplants. He was diagnosed when he was 4 and he died at 9 years old. And he was a very bright kid. I think his IQ must be 160 or something, because he would write books on like platelets, what platelets do. And we have something called Make-A-Wish here. And he wanted to go and do DNA testing in a lab for his Make-A-Wish. So you can imagine what sort of a kid he was. So when everything failed, he failed 2 transplants, and I inherited him from my colleague who left. His family actually told me that they would like to bring him in when he was dying to the hospital. And his mom said, "You are the second family he knows, because he's always been here since age 4. He's been to the hospital." So we had a very good home health. I was in Texas at that time, at Texas Children, and I actually did home PCA for him with our home health. But then mom called me and said, "I think it's time for us to come in." So I brought them in and I put him on continuous infusion morphine. He was in pain. You couldn't move him. And I added Ativan. I actually was, I wasn't that experienced like I am now. And that's why it was really very hard for me. And my fellows actually would feel, because we were giving him boluses. And one of my fellows said, I don't know if you have heard of Dr. Kevorkian. He was accused of killing patients for euthanasia. So one of my fellows told me that I feel like Kevorkian when I'm pushing the bolus for him. So I looked at her and said, well, if you're trying to kill him, you're doing a very poor job, because he's still in constant pain and his parents are looking at us to do something. So anyway, long story short, he was on 3 medications, continuous IV infusions. And there was this hospice doctor, Dr. Story, who I called to get advice. I asked my colleagues. They all said they had never used this much medications on anybody. And this 9-year-old was using so much medication. So I got a call from our ICU doctor who said, "Can I ask what's happening?" With Joseph, and I said, "Well, this is what's happening." So he said, "Do you mind if I come up?" Because you know what he told me? We were running out of morphine for Texas Children's Hospital, and they had to ask them to bring more morphine from Louisiana. So anyway, I asked, his name was Dr. Stein. Dr. Stein comes up and he saw Joseph. He looked at me, talked to the family, and he suggested putting Joseph on pentobarbital and sedation, which they use in the ICU. We were doing this on the floor. The nurses were amazing. So I finally put him on pentobarbital, continuous infusion, and he died the next day. So he didn't die immediately, but died the next day, and it was extremely peaceful. The parents were very grateful. And I learned, somebody came from Harvard, from Joanne Wolf's team, and we brought Joseph up because I had never used that much medication on anybody. And she actually recommended a book for me to read, and it's by Ira Byrock. He's a palliative care physician at Dartmouth who wrote this book called Dying Well. And if you can get it, I think it would be really good to read. And I read that book, and there was a chapter in that book because this lady told me to read that chapter, which was about a young woman who was dying, who had 2 kids. And she had the same situation. I was reading it, and I was saying, oh my God, this is what happened with Joseph. So this is called what I was talking about, spiritual pain. I told his parents to tell him it's okay, he can go, things like that. And finally, so this is what I wanted to talk about, principle of double effect. Aggressive treatment of pain at the end of life is legally and morally acceptable. Even if death is hastened by treatment, because a lot of physicians are afraid of that, provided the intention of the action, which is administering sedating medication, is to relieve pain and not to cause death. This concept is referred to as the principle of double effect, which we call PDE, and is an important underlying treatment principle in end-of-life care. An ethical consensus exists in the standard treatment of pain at the end of life, both in legal and religious settings, to alleviate suffering. And so whenever you're dealing with somebody like that, don't feel that you're, sometimes healthcare providers think that if we give this injection, they'll die and it will be our fault. That's not what you're doing. You are helping the patient. You're treating their pain. So I think I'm done with my talk. Thank you for listening. This is just Minnesota. And my references are this. There's a very good book called Paediatric Palliative Care Consultant, and up to date, of course. So open to questions.
So I think we have a case to discuss first. And for that, I would request Dr. Issa, fellow pediatric hematology oncology from Children's Hospital Lahore, to please present your case.
Assalamu alaikum. I'm Dr. Irsa. I hope you can hear me well.
Why can't we see the screen here?
So after the three very comprehensive talks, we'll just go quickly through this case and see the challenges that we face in our setup relating to, the oncology patients who are put on palliative care with the progressive and huge masses, which are not very nice to see physically as well. So I had this patient who was 12 years old male, and the family, they just came from a village. They had 30 days, almost a month admission with us. So the child presented with a 2 months history of a swelling on the right shoulder. And it was progressively enlarging, initially involved the shoulder only, and then it progressed to the neck. There was a lot of pain associated with this swelling. So when the patient came, he was hemodynamically stable, but we could see physically that huge mass on the shoulder. So this was the course of illness that we see in our setup. Usually patients come and the first thing that we see is that they just go and get some kind of spiritual treatment, like they go for some dumb type of treatment for that swelling and mass, maybe it will be cured with that. And after passing, some precious time there with that type of treatment, they we see these patients then, and a lot of precious time is already wasted there. Then second month of illness, there was multiple hospital visits. We had to do some, baseline diagnostic investigations, and they were ultimately referred to us for the curative treatment. So this was the huge mass on the right shoulder and some labs. And as you can see, it was almost 18 centimeter mass on the shoulder. So the, metastatic workup was negative and osteosarcoma was diagnosed on histopathology. So this was the bone scan. So for our diagnosis like this, we have, first we give neoadjuvant chemotherapy, we discuss an MDT and then see the resectability. And we usually, challenges with bone tumors, we have to talk about limb salvage, It is a big challenge when you talk about amputation with the family, and many patients and families just leave there and then when you talk about amputation or possibility that we may have to proceed with that. Chemotherapy was started, and then the toxicity of that chemo, we had to face the FN episodes. There was aggressive loose stools. Child had acute kidney injury as well. There was foul smelling discharge coming out of that swelling, and there were draining sinuses. The pus came positive for MRSA. Again, another challenge to treat. The disease was progressive, and we were unable to offer a curative treatment, and the child was really in severe pain. Again, the child developed bronchopneumonia, and ultimately he succumbed to death. And because of the good communication with the family and everything, the course of illness, the course of this time, all this time, painful time, it became a little soothing for the family and the patient as well. So the challenges that we faced were psychosocial and family concerns. So they, coming from a village, they have to visit, various hospitals for diagnostic workup. Then there was a delayed diagnosis. Parents had that guilt in themselves that maybe they delayed the diagnosis, and they were really regretting that time. So is it going to be a curable treatment or incurable? We had to tell them as well. Like just madam mentioned that you have to be honest with them at the upfront. So is it curable, uncurable, or are we just going to provide a symptomatic relief? What about amputation? Limited resources in our setup, especially pain management. We don't have the luxury of, morphine all the time. We are always short of that. And pain management is always compromised. So again, the socioeconomic status. So then again, there are spiritual concerns. And in our setup, we usually, it helps when they have this, this patience and this calm feeling that, yes, it is from Allah, and everything is planned in a certain way. So he was the youngest, very dear child of them. Parents and elder brother were the caretakers, and they lived far away. Again, another challenge, that coming from another village or far away area, you have to mobilize the whole family. Father is not working, and the financial concerns are also there. So this was the dynamics of the family. Father is the primary caretaker, but parents and siblings were there, plus the grandparents were also there. So our consultants and all of the team, they were in touch with the whole family, and we used to talk. But unfortunately, again, child being 12 years old could have been involved with the patient care, but he was not involved in the conversations. So advanced care planning was done later on. So again, as we have already discussed throughout the morning, pain management was a big challenge because of the mass, and we could not, surgically do anything because of thrombocytopenia and delayed coagulation profile. We could not just debride the wound as well. Posture change, because of the mass, the child could really not move around the bed to change his position. So bed sore, to how to avoid bed sores, how to counsel about the prognosis, poor oral intake, and again, weight loss. We have already discussed all of this. So just a comprehensive talk. So basically, these are the factors that we usually see in such cases.
I think go back to the last 5 challenges and we can have a feedback from the panelists. So I think I would add one thing here, that in that particular case, as Dr. Harun mentioned, that is the availability of morphine. So maybe it's not the availability of morphine all the time. In our setup, we don't have a team trained to manage the pain. So even if you prescribe some sort of morphine, so the patients do not get the adequate dose. For example, if you prescribe PRN doses, so the staff nurses would say that patient has just received a dose of morphine. And in this child, another challenge which we face, that despite prescribing morphine, every single day when we came up, patient had uncontrolled pain. And finally, we realized that one of our staff nurses was the actually strong advocacy from her side actually not to give morphine to the mother. That you are
Oh.
actually, आप तो इससे ज़्यादा दुश्मनी नहीं कर सकती है अपने बच्चे के साथ अगर आप उसको morphine देती
Yeah.
हैं. So this is the kind of scenario we actually face when we don't have the adequately trained team for palliative care.
Right. You need education for, to the team, because no, there are even here, there are some people who would do the same thing. So you have to definitely make sure that the team is on board with what you're doing and what especially with the pain management.
And I think as you have already taught us, Dr. Shakila, right, like pain assessment, evaluation, nature of pain, and what kind of pain it is, neuropathic hai, somatic hai, and then
Right.
again taking psychological component into account along with
Yeah.
the challenges of morphine and the
Right.
training of how to give pain medication. I think that's important.
Right. We use gabapentin and neurontin a lot too.
Yeah.
Along with the paracetamol and all. It depends on what you think is the pain. If it's neuropathic, absolutely, you should. It helps.
Multimodal analgesia
Absolutely.
works
Absolutely.
best.
Exactly.
I had a question. Yeah. For Dr. Shakila, you mentioned about how paracetamol can be used effectively for pain management. Many times children who are admitted with febrile neutropenia, sometimes there's a concern that giving paracetamol may actually mask any further fever spikes. And so you're not really sure when you can actually discharge those patients or you would feel comfortable. Any comments on that, please?
Oh, yeah. I'm one of those, our nurses used to tell patients not to give. I have never had fever being masked by using paracetamol. The fever, if it's, the fever will come. It will not go away. But treating febrile neutropenia is a separate thing than pain management. So if the patient is in pain, absolutely, I would use it. But I don't think that you can hide the fever with just by using paracetamol. The fever will actually not go away if there is a reason for it with infection or anything. It will, despite your using paracetamol, the patient will be febrile. So, but with neutropenic patients, you don't use non-steroidals because of the effect, because mostly they're, have low platelets too. So your best drug is Tylenol. And now, I don't know, you don't have IV Tylenol there, do you? Because now we have IV Tylenol here. It's very expensive, but it's available for patients.
We do have IV paracetamol here.
Oh, good. So that's another
Yeah,
way.
and in hospital settings, more in use as compared to the oral one.
Yeah,
Unfortunately.
I don't use IV Tylenol for, unless the fever is very high or something like that. When in transplant, the patients are febrile for 3-4 weeks. So, that's where our IV Tylenol helps. But oral, if they can take orally, you use the oral route. That's the best.
So I have a, sorry, go ahead.
I have
So the thing with paracetamol, Dr. Shakira, is that we don't want our junior doctors and our parents to actually have paracetamol at home, because they will keep on giving it paracetamol and then they will not come to the ER if they're on active cancer therapy and are neutropenic. So in my practice, sometimes when it is essential, I do give them paracetamol, but these are somewhat educated parents, and I do tell them to check their temperature and to report to the ER. But generally the other patients, because they will give paracetamol and because the fever settles down, they will not come to the ER.
No, I get that. But our patients are all instructed that fever, call, it's an emergency with neutropenic fever, so you have to come to the ER. So
I have a question, Dr. Shakila. In our patients, for example, particularly in solid tumors with stage 4 disease, and they are on kind of palliative care, and you have to give the analgesia for a longer time. And once you put them on opioids, do you still continue with paracetamol or adjuvants like ibuprofen or paracetamol?
yes,
And then For example, if the opioids are like a 4-hourly, so how do you actually measure the effect of paracetamol in presence of opioids?
No, you don't have to measure the effects. You are trying to control the pain. So the goal is to get something the patient can take to control the pain, so they get things more frequently. So we use a combination. We use opioids and paracetamol. So you're not trying to really measure if the paracetamol is effective, but if you're using opioids, that means the pain is severe enough for you to add the opioids.
Sure, but actually measurement means actually how do you know that this is the pain controlled by the opioids actually or the paracetamol? Because
do you care?
Obviously paracetamol has some toxicity and organ damage. And then it's all about the use of paracetamol in longer run for like maybe days and weeks then.
We are talking about palliative care. Do you care which drug is more effective? You're trying to control the pain. So your goal is to trying to control the pain.
Can I just add to that, to your question? So what happens in cancer is a complex cancer pain. So multiple receptors are involved. So the opioids would only work on the opioid receptors, but there is neuropathic pain as has been discussed and other. So you by targeting all the receptors using paracetamol, NSAIDs, neuropathic agents, and opioids. So they're all going to act and control the pain, not by just targeting one receptor.
Yeah, that's true.
Right. That is
Not
the
yet
idea
talking about
behind
the
it.
neuropathic
So
pain
that's
and
the idea.
gabapentin,
This is what I'm saying. Do you
and
care
we
which?
put all the patient at gabapentin, but the question is particularly for paracetamol actually.
Yeah.
And,
So paracetamol is also going to,
in
you know,
presence of opioids, actually.
absolutely. So it's kind of like a synergistic effect acting on all the receptors and controlling the pain, as Dr. Shakila is saying, that it's the pain throughout the day, and opioids will only be given at a particular interval. You can't just, keep on using it every, a few minutes or everything, or every few hours. So by targeting all the receptors and by adjusting the medications round the clock, that is how, because the ultimate aim is to control the pain.
Right. Agreed.
I have a question, Dr. Shakila. So since we were talking about use of NSAIDs and avoiding NSAIDs because of low platelets in our population. So I was wondering about how's your experience about using COX-2 inhibitors like celecoxibs and all? They have a least effect on platelet function, platelets functions and all. So have you ever used COX-2 inhibitors, and how are the results? And
yeah, we don't use them very often now because there have been studies showing that, they have a lot of side effects, especially in children. But when you're doing end of life and, care, we stop checking CBCs, just to let you know. I don't even check a CBC or any labs. So, but what we do is we base our, bleeding, I would give platelets to the patient if I see any evidence of bleeding. But we use non-steroidals at that time because if we are, trying to control the pain, you use whatever agents you think are effectively controlling it. So paracetamol, non-steroidals, opioids, you could use whichever would control the patient's pain, as I said. And as I explained to you, I have used epidurals, we have used, PCAs and blocks, anesthetists help us with that. Especially like in this patient with the shoulder pain, maybe a nerve block may have helped him. So, you do nerve blocks. So the goal is to just make sure the patient is comfortable. So whatever works.
So one of the things, Resham, have you ever used dexamethasone for bone pain? Because I don't know if you've talked about that, because I think that's pretty effective as well, right?
Dexamethasone, and also, NSAIDs and dexamethasone helps best with the bone pains. And of course, methadone, but we do not have that option of having methadone here. But yes, Dexa.
Okay, thank you very much, Dr. Shakila, for the talk. Just to let everyone know that the pediatric palliative session was the first time we had it in the symposium this year, and we hope to continue this activity. So I would like to thank all the speakers, Chair Dr. Huma, and the participants, as well as the participants online for having a wonderful session since 9 this morning. And I think, like I mentioned before, it could go on forever. So thank you very much. We will close the session now, and we will have a group photo just now. Thank you very
Okay.
much, and hope to
Thank
see you
you.
again, inshallah,
Khuda
next week.
Hafiz.
Dr.
Thank you
Dr.
so
Shakila,
much.
thank you
This
so
was so
much
great.
for joining.
No problem. You're very welcome.
Okay,
It
Dr.
was a
Shakila,
my
can you
pleasure.
just spare for a minute? We'll take you in the group photo.
Oh, okay.
Okay.